All right. Welcome back, everyone. Thank you for your patience. The time is 12:07 p.m. and we will resume the public portion of this meeting. Mr. Saeed, can you please announce the next item?
Next up on the agenda is approving the minutes of both the Commission's open and executive sessions held on May 8th. The minutes have been shared with the members of the Commission prior to this meeting.
Thank you. If there are no edits or changes to the meeting minutes, is there a motion?
Madam Chair, I motion to approve the minutes.
Commissioner Nash moves to approve the meeting minutes. Is there a second?
Second.
Seconded by Commissioner Del Cid Coso. Any discussion on this motion? Hearing none. All those in favor of approving the meeting minutes say aye.
Aye.
Aye. All those opposed say nay. Any abstentions? Motion passes.
The next item on the agenda is the Chair's report.
Thank you. Good afternoon, everyone. A couple of items that I want to raise today. This week is Juneteenth. Juneteenth is just in a couple of days. So as we commemorate the time when the last enslaved people were informed of their emancipation, we must also acknowledge the ways in which the legal system was weaponized against Black people. And this includes the national political efforts that explicitly targeted Black communities for substance use, cannabis among them. Now, here in New Jersey, the past disproportionate arrests for marijuana possession left Black communities facing disproportionate collateral consequences for an arrest. And with New Jersey's historical 2020 ballot question to legalize cannabis, which undoubtedly changed how Black people could engage with cannabis a bit more freely. But Black justice isn't just about criminal justice. The policies implemented by the Cannabis Regulatory Commission prioritizes people with prior marijuana convictions and minority-owned businesses for access to the economic opportunities that come with a legal cannabis industry. And as a result of our efforts, nearly 1 in 5 licenses awarded by the Commission went to people with a prior marijuana conviction, and 12% of annual licenses went to Black-owned businesses. While undoing the vestiges of race-based slavery certainly requires more than what the New Jersey Cannabis Regulatory Commission can do, the Commission will continue to do its part to advance equity in the cannabis industry. June is also Pride Month, so happy Pride Month to everyone. And I want to take a moment to acknowledge the intersection of cannabis legalization and LGBTQ+ issues, which goes back decades. Not only did the fight for legal recognition of the two follow similar paths, but the LGBTQ+ community in particular helped advance the availability of medicinal cannabis for patients facing serious conditions. Decades ago, many in the LGBTQ+ community turned to cannabis for relief from medical conditions, notably HIV and AIDS. Facing a trifecta of headwinds in the eyes of mainstream society, their gender or sexual identity, HIV or AIDS positive status, as well as being a cannabis user, brave individuals in this community played leading roles in the national recognition for the medicinal benefits of cannabis. As a result, the federal government recognized medical use, the benefits of medical use of cannabis when it approved 2 drugs for treating symptoms of HIV and AIDS in 1992 and in 2016. And New Jersey included HIV and AIDS as qualifying conditions for medical conditions. Included HIV and AIDS as qualifying medical conditions at the outset of establishing its medicinal cannabis program. While even years later, Black people, LGBTQ individuals, and cannabis users still face significant negative stigmas in many parts of America, including here in New Jersey. But I want to take this time to thank all three of these communities for their commitment, courage, and activism in fighting for a stronger, fairer, and more open world, one with even more beauty, color, and culture and flair. Lastly, I want to go over a few industry reminders. So our application materials, if you are an applicant, we understand that everyone is eager to get on a board meeting agenda for consideration at a board meeting. But your application materials do need to be submitted at least 4 weeks in advance. We have a lot of inactive applications just sitting in the application portal and unable to advance through the approval process because the business isn't responding to CRC staff and JCRC staff when we are reaching out to fix their deficiencies in the application. So please, please, please ensure your contact information is up to date and correctly listed in your application. Check your spam folders and your voicemail. And also contact the Office of Diversity and Inclusion, our Office of Licensing, or your assigned investigator if you have questions about how to fix a deficiency in your application. If you fail to cure or fix your application, you won't be able to move forward. Please note that we also require business individuals who are requesting commissioners or commission staff to speak at an event. We need you to submit your requests at least 4 weeks in advance. That allows us the time that we need to process your request, get necessary logistics in place for participation. We're thrilled that we have a lot of individuals who are interested in hearing from the commission, and the commission is happy to participate in community events and educational events across the state so that we can bring up-to-date and accurate information to participants. But we do need those requests to be submitted well enough in advance that allows us to prepare for them. And the last thing I'll note is that the Commission will be reviewing the concerns that were raised about the accessibility of some of our licensed facilities. We encourage all of our licensees to ensure that their premises are accessible for people with disabilities. And I especially hope that our ATCs, which are required to serve patients, are making their premises accessible. So more to come on that front. And that is all that I have for today's chair's report.
Next item on the agenda is the executive director's report.
Thank you. For this, I will turn it over to our now acting executive director, Christopher Riggs. The floor is yours.
Thank you, Chairwoman, and thank you for that chair's report. I echo all of the sentiments that we raised in that chair's report. It was very well done. Before I get into the executive director's report, I do want to briefly mention that the CRC is also looking to operationalize a virtual component to our public comment section of our meetings. So our in-person meetings will have, people will have the ability to join virtually and provide comments to the commission. More to come on that. As soon as we have more information to share, we will share that. I'm going to update us on dispensary openings. So we have more than 140 medical and recreational dispensaries open in the 21 counties. The good news is that we have at least one licensed cannabis dispensary in every county in the state of New Jersey. That is a good milestone to reach. Each county is now has a dispensary that's operational. The new recreational only dispensaries that have opened since our last meeting: Cream Cannabis Dispensary in Jersey City, Doobies in West Milford, Enlighten Health and Wellness in Marlton, the Healing Side in Atlantic City, Moja Life right here in Trenton, One Greenleaf in Gibbsboro, Sea and Leaf in North Cape May, and Twisted Hat in Carneys Point. The next item that I will update on is the licensing update. So this is the recreational licenses that we've received, that have been approved since June 4th of 2024. We have a little less than 1,500 conditionals that have been approved, 338 conditional to annual conversions, 176 direct to annual licenses, and 77 expanded ATCs, to have a grand total of 271 total operating licenses in AU and permits in medical. Of those licenses approved as of June 4th of 2024, these are the applications that have been submitted. A little more than 2,500 applications have been submitted through our licensing portal. We're just shy of 2,000 of those applications being approved. 108 applications are under review in the Office of Licensing. 312 applications are pending resubmission following a cure. And 145 applications are under review in the Office of Compliance and Investigation. Today, what is recommended to the board, what is up for consideration, we have 15 conditional applications. We have 12 applications that are going from conditional to annual. We have 6 annual applications. We have 1 request to be an expanded ATC, and we have 18 annual renewal applications. As always, we'll give a current update to our medical program. Right now, as of June 10th of 2024, total active patients are 76,316. We have almost 5,000 caregivers and a little over 1,500 doctors enrolled in the program. This is one data point that I wanted to raise here, and this is about municipal cannabis tax revenue. This is estimated from Q1 of 2024. The first graphic up top, the first chart, shows by region the cannabis sales and the projected municipal tax revenue that could be gained by a municipality if they opt to have a 2% tax on cannabis sales. So as you'll see, in the central region, there was 75,949,326 in total sales, which would equate to a little over 1.5 million in municipal revenue, and that goes on through the process for a grand total of approximately 4 million in total revenue that a municipality could have, that all the municipalities could have seen from Q1 of 2024. It's also broken down in the bottom here, where we broke it down by county in the average per the quarter, and then to the right of the other chart here has the municipalities. So we also have an average, and we broke it down with a median as well, because there are some outliers. But there is a revenue stream for municipalities to gain by opting in and allowing cannabis businesses to operate in their locality. And we look forward to having more municipalities opt in so that we can see more cannabis businesses thrive. And that is all for my executive director's report. I will turn it back to you, Madam Chair.
Next item on the agenda are the committee reports.
Thank you, and thank you, Director Riggs, for your first solo executive director's report. For our committee reports, I will turn it over to our Permitting and Licensing Committee's Chair, Commissioner Del Cid Coso, to give a readout on that committee's work.
Thank you, Chairwoman. Good afternoon, everyone. Quick update on the conditional extensions for this month, last month actually, May 2024. We issued 39 conditional extensions. And I wanted to take this time to to do a recap for not only my fellow commissioners, but the public of what happened during our listening session that took place on May 16th. We had a very good conversation for 2 hours with the public, and I do want to thank those who registered to speak. We learned a lot from all of you. Your comments were really well received by the committee. And just a quick recap of what were some of those comments. So most of the feedback that we heard were issues concerning things that are happening at the local level. Many of those are out of CRC's purview, but we did hear that municipalities have created long and complicated processes. Real estate continues to be very limited in those communities. And in addition to that, micro businesses are having a hard time finding new locations due to the size and requirements. I do want to remind folks that we do have a page that was newly created on our website. I don't know if many of you have seen it, but we have a list of the 204 municipalities that have opted in. They are listed under the government relations page on our website. So feel free to look at that as a resource. There's a continuing ask for additional access to capital and funding as another issue that was brought up during the discussion that we had. And there were a few comments asking the CRC to reevaluate the requirement on keeping 2 separate inventories for those ATCs that are serving the adult use consumers and medical patients. So what is next for our committee? We are hoping that to conduct about 2 to 3 focus groups this fall. We're going to have more details about that. We're working out the logistics with the committee, so stay tuned for more details. And the purpose of this committee, for this listening session and the committee overall is for us to review and evaluate or any potential change needed to streamline and improve our application and licensing processes. I think it was very helpful, the comments that we received. And I do have to point out that, some of the comments that were made are things that we can change in regulation and some things that need to be done by changing the statute. So I think that we need to kind of evaluate those comments and see what we can and cannot do based on our regs and statutes. So I think it was, we had a really good conversation. We're hoping that this is not the last listening session that we'll have with the public on this issue. But again, thank you to everyone who came and spoke for the 2 hours that we allocated for this discussion. And that concludes my report unless Chairwoman Ueno has anything else to add.
Thank you, Commissioner Del Secoso. No, I have nothing further to add. I echo your sentiments and your gratitude towards the individuals who participated in the listening session, and I look forward to the forthcoming focus groups.
Next item on the agenda is the consideration of procurement of customer relationship management services.
Thank you. Director Riggs, I will turn it over to you to provide a summary of this proposed procurement.
Thank you, Chairwoman. We are recommending the procurement of Salesforce, which is a cloud-based customer relationship management platform that staff will use so that we can continue to safely and equitably regulate New Jersey's legal cannabis market by building various workflows and process automation. This will allow our staff to automate the processes across all of our IT systems. It'll bring all of our systems and data sources together into seamless workflows, and it will provide efficient and effective interactions among CRC employees, as well as the key internal and external stakeholders. So we are recommending procurement of the Salesforce platform, and I will turn it back over to you, Chairman.
Thank you, Director Riggs. Are there any questions from the board for Director Riggs regarding the information presented? Seeing no questions, is there a motion on this item?
Madam Chairwoman, I move that we accept Director Riggs' recommendation.
Madam Chair, I second to approve the resolution for Salesforce software.
Thank you. Is there any discussion on this motion? Hearing no discussion, Mr. Saeed, can you please call the vote?
Commissioner Barker,
Aye.
Commissioner Del Secoso,
Yes.
Commissioner Nash,
Yes.
Vice Chair Delgado,
Yes.
Chairwoman Ueno.
Yes.
The motion passes. Next item on the agenda is the consideration of applications for ownership changes.
Thank you, Director Riggs. I'll turn it back over to you to provide a summary of the ownership change applications received.
Thank you, Chairwoman. We have 4 ownership changes up and for consideration and recommended to the board to approve today. All of the owners and officers have been vetted as required by the law and regulations and have been deemed qualified by staff to hold the positions in the adult use cannabis market. And therefore, we recommend that these 4 ownership changes be approved. Thank you.
Thank you. And, oh, there we go. Great. Thank you, Director McWhite. Are there any questions from the board regarding the information provided for these 4 business ownership transfer applications? Hearing none, is there a motion on this matter?
Madam Chairwoman, I approve the resolution approving the request for transfer of the for ownership transfers.
Moved by Vice Chair Delgado. Is there a second?
Second.
Seconded by Commissioner Del Coso. Is there any discussion on this motion?
Brief discussion, Madam Chair.
Commissioner Barker.
Just want to stress to the industry, to awardees, potential investors, please, we cannot stress this enough. Please refrain from predatory practices. To the awardees, I would just please stress that you have somebody review any and all agreements before you sign them and enter into them. If you can't afford an attorney or you don't have the privilege of having an attorney review it, please reach out to our office, try to get in touch with the ODI team, or reach out to New Jersey Business Action Center. They can try to provide you some guidance as much as they can, to a limit, but we do want to make sure somebody is reviewing these agreements, so that way you understand whether or not you're getting fair terms. Thank you very much, Madam Chair.
Thank you, Commissioner Barker. One caveat to what Commissioner Barker said is that the Cannabis Regulatory Commission cannot give business or legal advice. So while the personnel and the staff here at the commission is more than happy to point people in the right direction, give you resources that may aid you in making your business decisions, we cannot tell you, we cannot advise you on what the decisions you make should be. So just that one little caveat there. Any other any further discussion on this motion to approve the ownership transfer applications? Hearing no further discussion, Mr. Saeed, can you please call the vote?
Commissioner Barker,
Abstain.
Commissioner Del Coso,
Yes.
Commissioner Nash,
Yes.
Vice Chair Delgado,
Yes.
Chairwoman Waynu.
Yes.
The motion passes. Next item for consideration are the adult use cannabis business conditional license applications.
Director Riggs, I will turn the floor to you.
Thank you, Chairwoman. We have 15 conditional licenses that are recommended for approval. There is 1 cultivator, 2 manufacturers, 2 wholesalers, 8 retailers, and 2 delivery licenses that are recommended. All of these licenses have followed our licensing process. They've been given a priority assignment. It's been confirmed that each application was assigned to the appropriate review level. The priority was then verified. We have confirmed that all the appropriate documentation was submitted to the commission to support the priority designation. There was a completeness review check done by our licensing team to confirm that all required documents are submitted for a conditional license. And then the applications are moved and scored appropriately and then recommended to the board for approval. These 15 conditional licenses have followed that process and we recommend that they be approved. Thank you.
Thank you. Are there any questions from the board? Hearing none, is there a motion on this matter?
Madam Chair, I move to approve the resolution for conditional license applications.
Moved by Commissioner Nash. Is there a second?
Second.
Seconded by Commissioner Del Coso. Is there any discussion on this motion? Hearing none, Mr. Said, can you please call the vote?
Commissioner Barker,
Aye.
Commissioner Del Cid Coso,
Yes.
Commissioner Nash,
Yes.
Vice Chair Delgado,
Yes.
Chairwoman Waynu.
Yes.
The motion passes. Next item up for consideration are the adult use cannabis business conditional license application denials.
Director Riggs, floor is yours.
Thank you, Chairwoman. Fortunately, we only have two conditionals that we are recommending for denial today. These are for non-payment. Basically, they've been provided various notice to make their payment for their license award, and they have not paid. So we would recommend these two conditionals be denied at this time. Thank you.
Thank you. Any questions from the board or Director Riggs? Hearing no questions, is there a motion on this matter?
Madam Chair, I move to adopt this resolution concerning the denial of Class 5 and Class 2 annual licenses.
Is there a second?
I second.
Is there any discussion on this motion? Hearing no discussion, Mr. Said, can you please call the vote?
Commissioner Barker,
Abstain.
Commissioner Del Cid Coso,
Yes.
Commissioner Nash,
Yes.
Vice Chair Delgado,
Yes.
Chairwoman Waynu.
Yes.
The motion passes. Next item up for consideration are the adult use cannabis business conversion license applications.
Thank you. Director Riggs, I'll turn it back over to you for a summary of these applications.
Thank you, Chairwoman. So these follow the same process. We have 12 conditional to annual conversion licenses, 2 cultivators, 1 manufacturer, and 9 retailers. They follow the same similar process to be approved for their conditional license with priority assignment, priority verification, completeness review, and then they were scored. But the additional step here is that there was a qualification review, the individual's financial sources, management services agreements, and any other relevant documents related to the business were reviewed for regulatory compliance. Background checks were conducted on all the individuals and owners to ensure that they meet the statutory standards to operate in the adult use cannabis space. There was quality control conducted by the Office of Licensing, Compliance, and our legal office. And we are now recommending that these licenses be approved by the board.
Thank you. And I believe we have a list of those applications. There we are. Great. Thank you. Are there any questions from the board regarding these applications? Hearing no questions, is there a motion on this matter?
I move to approve the resolution for applications to convert from conditional to annual.
Madam Chairwoman, I second that motion.
Moved by Commissioner Nash and seconded by Vice Chair Delgado. Is there any discussion on this motion? Hearing no discussion, Mr. Said, can you please call the vote?
Commissioner Barker,
Aye.
Commissioner Del Cid Coso,
Yes.
Commissioner Nash,
Yes.
Vice Chair Delgado,
Yes.
Chairwoman Waynu.
Yes.
The motion passes. Next item up for consideration are the adult use cannabis business annual license applications.
Thank you. Director Riggs, I'll turn it back over to you.
Thank you. We have 6 annual licenses that are up for consideration today and recommended for approval. 1 cultivator, 1 manufacturer, 1 distributor, and 3 retailers. These have followed a similar licensing process where priority assignment was given, that priority was verified. They've gone through completeness review. They've been scored. There was a qualification review of the individuals and to ensure that any of the documentation submitted complies with the regulations. We had a quality control done by our Office of Licensing and Office of Compliance and our legal team. And now we are recommending that these licenses be approved by the board. Thank you.
You. Are there any questions from the board? Hearing no questions, is there a motion on this matter?
Madam Chairwoman, I move that we accept the resolution for annual license applications.
Is there a second?
Second.
Is there any discussion on this motion to accept the resolution for annual license applications? Hearing no discussion, Mr. Said, can you please call the vote?
Commissioner Barker,
Abstain.
Commissioner Del Cid Coso,
Yes.
Commissioner Nash,
Yes.
Vice Chair Delgado,
Yes.
Chairwoman Waynu.
Yes.
The motion passes. Next item up for consideration is the expanded alternative treatment center certifications.
Thank you. Director Riggs, the floor is yours.
Chairwoman. We have one expansion for Theory Wellness of New Jersey, which is a Class 5 retailer here in Trenton. They requested to be expanded. They have the zoning and municipal approvals. All labor requirements are met. Under the law, they are required to certify that they have sufficient quantities of medical cannabis and medical cannabis products available to meet the reasonably anticipated needs of registered qualifying patients, and they have done so. They have met all statutory and regulatory criteria, and therefore we are recommending approval of their expansion into the adult use market. Thank you.
Thank you. Are there any questions from the board? Hearing no questions, is there a motion on this matter?
Madam Chair, I move to approve the resolution certifying Theory Wellness of New Jersey to expand operations to the AU cannabis market.
Moved by Commissioner Nash. Is there a second?
Second.
Seconded by Commissioner Del Cid Coso. Any discussion on this motion? Hearing no discussion, Mr. Said, can you please call the vote?
Commissioner Barker,
Abstain.
Commissioner Del Cid Coso,
Yes.
Commissioner Nash,
Yes.
Vice Chair Delgado,
Yes.
Chairwoman Waynu.
Yes.
The motion passes. The next item up for consideration are the adult use cannabis business annual license renewal applications.
Thank you. Director Riggs, floor is yours.
Thank you, Chairwoman. These renewals obviously followed our licensing process and were licensed. Some are 1-year renewals, some are in their 2nd year of renewal. One thing that I do want to mention on this renewal process is that during the course of the year, these businesses need to ensure that all material changes are reported to the commission throughout the year. Our regulations require that. Material changes should not be submitted on the renewal application unless they happen right at the time of renewal. We should have these material changes reported to the commission and approved, as we just did previously with our ownership changes in this public meeting. I want to ensure that all businesses understand that our regulations require that material changes be reported to the commission, and so that our Office of Compliance can review and process those changes and present them to the board for approval during the course of the year. The annual renewals are up on the screen right now. And I believe there's one other slide with some other annual renewals. We are recommending that these renewals be approved. They've followed the process, they've satisfied the statute and the regulations, and therefore we recommend approval. Thank you.
Thank you. Are there any questions from the board regarding the annual license renewals? Hearing none. Is there a motion on this matter?
Madam Chairwoman, I move that we accept the resolution for renewal of adult cannabis business license.
Moved by Vice Chair Delgado. Is there a second? Vice Chair Delgado moves that we accept the resolution for the annual license renewals. Is there a second?
Second.
Seconded by Commissioner Del Cid Coso. Is there any discussion on this motion? Hearing no discussion, Mr. Said, can you please call the vote?
Commissioner Barker,
Abstain.
Commissioner Del Cid Coso,
Yes.
Commissioner Nash,
Yes.
Vice Chair Delgado,
Yes.
Chairwoman Wenu.
Yes.
The motion passes. The next item up for consideration is another annual license renewal that Commissioner Del Cid Coso has been recused from.
Yes. So Commissioner Del Cid Coso has recused herself from the application concerning Brute's roots. On account of her recusal, she will remove herself from the Zoom meeting while the board considers this particular application. Afterwards, Commissioner Del Cid Coso will rejoin us and will take up the next order of business. So I see that Commissioner Del Cid Coso has logged off. So I will now turn it over to Director Riggs to provide a summary of this particular renewal application.
Thank you, Chairwoman. Similar to the 17 others that were just approved by the board, Roots has submitted all the renewal documentation as required. And I will echo that material changes need to be reported to the board when they happen during the course of the year. Not when you're coming up for renewal, when they happen during the course of the year. But we are recommending that Roots first year of operations annual license be renewed. Thank you, Madam Chair.
Thank you, Director Riggs. Are there any questions from the board? Hearing no questions, is there a motion on this matter as it relates to Brute's roots?
Madam Chair, I move to approve the renewal for Brute's Roots.
Is there a second?
I second it.
Seconded by Vice Chair Delgado. Thank you. Is there any discussion on this motion? Hearing no discussion, Mr. Said, can you please call the vote?
Commissioner Barker,
Abstain.
Commissioner Del Cid Coso is recused. Commissioner Nash,
Yes.
Vice Chair Delgado,
Yes.
Chairwoman Wenu.
Yes.
The motion passes. The next item on the agenda are cases, claims, and petitions.
All right, we will give Commissioner Del Cid Coso just a quick moment to log back on. And as soon as she does, Director Riggs, I will turn the floor over to you. We do not have any consideration of adult use of application denials, any additional application denials. Apologies for that slide, folks. All right, so
Slide, please. Is Commissioner Del Cid Coso back, Chairwoman?
yes, she is. Go right ahead, Director Riggs.
Thank you very much. We have 3 ATC employees that have submitted the relevant documentation to show that they are rehabilitated and able to work in the medical cannabis space. They provided the relevant, clear, and convincing evidence to show that they're rehabilitated and able to work in the industry. There are disqualifying convictions in the statute. That is why the rehabilitation was triggered. They have met their burden and provided us with the information necessary to show that they are rehabilitated, and therefore we are recommending approval of their rehabilitation status. Thank you, Madam Chair.
Are there any questions from the board regarding these claims and petitions? Hearing no questions from the board, is there a motion on this matter?
Madam Chair, I move to approve the request for a determination of rehabilitation by ATC employees.
And I second that, Madam Chair.
Moved by Commissioner Nash and seconded by Vice Chair Delgado. Is there any discussion on this motion? Hearing no discussion, Mr. Said, can you please call the vote?
Commissioner Barker,
Aye.
Commissioner Del Cid Coso,
Yes.
Commissioner Nash,
Yes.
Vice Chair Delgado,
Yes.
Chairwoman Waynu.
Yes.
The motion passes. Next item on the agenda, we have notices of enforcement actions.
Director Riggs, I will turn it over to you for a summary of these enforcement actions.
Thank you, Chairwoman. We have two enforcement actions that are up for consideration by the board today. The QCC group, which is NOV 90-24, and Full Tilt Labs, which is NOV 95-24. These are for violations related to their diversely owned business status. Our Office of Licensing became aware of these violations through a routine audit of the Division of Revenue and Enterprise Services database. It was determined that they failed to maintain certification indicating that they were a diversely owned business as required by our regulations. Therefore, a notice of violation was issued, and we are now at the enforcement stage. We have recommended to the board that this is a Category 5 violation, and it is their first violation. And I will leave it up to the board. Thank you.
Thank you, Director Riggs. Are there any questions from the board for Director Riggs?
Yes. I just wanted
Commissioner Nass.
to clarify that this was, these violations were an administrative oversight and were not a reflection of any ownership or organizational changes. Is that correct?
That is correct. These were, an administrative oversight from what we've uncovered during our investigation. It wasn't any change to the ownership status of these entities that caused them to be in violation of the regulations. That is correct.
And they responded by submitting the door certificate promptly?
Yes, my understanding is that both are now recertified and maintain their diversely owned business status. Have that certification.
Thank you.
You're welcome.
One follow-up question, Acting Director Riggs. Did either of the violations pose a significant risk or threat to public health?
In my opinion, no, they did not pose an immediate concern or any concern related to public health or safety.
Thank you.
You're welcome.
Thank you. Any other questions from the board? All right, we will take these one at a time. So with respect to the first NOV-90-24, is there a motion on this matter?
Yes, Madam Chairwoman, I have a motion.
Vice Chair Delgado?
I move on the action on QCC Group LLC. I move for a $250 fine.
Vice Chair Delgado has moved to impose a $250 fine. Is there a second?
Second.
Second.
Seconded by Commissioner Nash. Any discussion on this motion to impose a $250 fine? Vice Chair Delgado, if you could please, I'd like to hear your thinking, your rationale for this particular fine.
It was a first offense. It was administrative oversight. Very simple. And I just want to be consistent on what, on the fines that I believe in. And that's my rationale. First time offense and it's administrative oversight.
I believe that's a reason, excuse me. I believe that that is a reasonable landing place for first offense for an administrative oversight here, especially in light of the communication and responsiveness of the business to provide to rectify the situation and get a valid certification for their diversely owned status. Is there any further discussion on this motion to impose a $250 fine? All right. Hearing no further discussion on the motion to impose a $250 fine in response to NOV-90-24, Mr. Saeed, can you please call the vote?
Commissioner Barker,
Aye.
Commissioner Del Cid Coso,
Yes.
Commissioner Nash,
Yes.
Vice Chair Delgado,
Yes.
Chairwoman Waynu.
Yes.
The motion passes.
So we'll turn now to the second enforcement action item, NOV-95-24. Is there a motion as it relates to this item?
Yes, Madam Chairwoman, I have a motion.
Vice Chair Delgado.
I move that we find Full Tilt Labs LLC a $250 fine.
Is there a second?
Second.
Seconded by Commissioner Del Cid Coso. Any discussion on this motion? Vice Chair Delgado, same question again that I'll pose to you here. If you could provide the rationale for the $250 fine.
Same, Madam Chairwoman, same rationale, first offense, administrative oversight, and I behooves the commission to be consistent. And I think the $250 fine is consistent with the previous fine.
I tend to agree. Thank you, Vice Chair Delgado. Is there any further discussion? Hearing no further discussion on the motion to impose a $250 fine in response to NOV-95-24. Mr. Saeed, can you please call the vote?
Commissioner Barker,
Aye.
Commissioner Del Cid Coso,
Yes.
Commissioner Nash,
Yes.
Vice Chair Delgado,
Yes.
Chairwoman Waynu.
Yes.
The motion passes. The next item on the agenda, we have the open public comment period. We have invited guests that we are going to invite first to speak.
Yes, thank you, Mr. Saeed. So as we as we prepare for the public comment period, I do want to note, as we do at every board meeting, that members of the public can submit public comments during or after this meeting in writing via our website, nj.gov/cannabis/meetings. And the deadline for submitting written comments for today's public meeting is 5 o'clock tomorrow, Tuesday, June 18th. Written comments will be shared with the commissioners and they will be made public. So for today, we have 3 specific topics that we want to hear your thoughts on. And as Mr. Saeed mentioned, as Mr. Saeed noted, we will hear first from our invited speakers, who will each have 5 minutes to share their comments, and then we'll open the floor to members of the public who register to speak. And members of the public will have, as we usually, in accordance with our standard practice, will have 3 minutes to share their comments. So on the first, I just want to highlight for our attendees our 3 topics that we are particularly highlighting today. Qualifying medical conditions for the medicinal cannabis program. Currently, we have 17 medical conditions approved for participation in the program. Should any other medical conditions qualify for the program participation? Why? And how can medicinal cannabis effectively serve people facing other medical conditions? Second item, the second topic is research. How can the Commission support scientific cannabis research efforts? Clinical registrant permits provide one opportunity for institutions to assess patient health and safety in the medical program, but what other pathways should the Commission consider to promote or incentivize appropriate scientific research? And then lastly, our third topic is healthcare provider access. How can healthcare providers be encouraged to support patients interested in enrolling in the medicinal cannabis program? And how are providers learning about the medicinal benefits of cannabis? So we want to hear from you. We'll first hear from our invited speakers. When you do hear your name called, please raise your hand in the Zoom feature, in the Zoom platform, apologies, and our staff will be able to unmute you. When we turn to our members of the public, staff will call out our registered commenters in the order in which they registered. When you hear your name called, you please raise your hand in the Zoom platform so that we can unmute you. If your name does not match if your name in the Zoom platform does not match the name that you used to register to speak, we may not be able to identify you. So it is important that you ensure that your name is accurately spelled in the Zoom platform. If you're not sure what your name looks like in the Zoom platform, log out, immediately log back in, at which time you should be prompted to enter your name. And from there, we will be able to accurately identify you. So with that, I will turn it over to Mr. Saeed and Director Blake Director McWhite to call on our first invited guests.
All right, testing. The microphone is on. Yes, wonderful. So I am going to call the first three invited speakers. I ask that you raise your hand. First, Dr. Elizabeth Von Boxdale, Ken Wolski, and Nichelle Santos and Gaetano. If you three can raise your hands, or four can raise your hands, I will allow you to talk one at a time. Thank you so much. And Dr. Elizabeth Von Boxdale, you are first, and please just state your name and your affiliation group or organization before you start. And I do have your slides queued up, Dr. Boxdale.
Thank you so much, and good afternoon, everyone. Thank you for having us and allowing us to speak with you today. My name is Elizabeth Van Boxdale. I am a neuroscientist. I work at Drexel University. For many years, I've conducted NIH-sponsored research on the endocannabinoid system and the body's response to stress. I'm also joined by two of my colleagues, Dr. Robert Sterling, who is a professor and clinical researcher and has done abundant research on substance use disorder as well as cannabis research, and Dr. Jennifer Ross, who is an assistant professor who initiated her research on cannabis in preclinical models and has transitioned to clinical research to understand how different strains of the marijuana plant affect different medical conditions. We are here today to advocate for more effective education and a clear connection between education and research. If you could go to the next slide. There really is a critical need to introduce effective, comprehensive education for healthcare providers at every clinical level, from pharmacists to physician assistants, nurse practitioners, and medical doctors in training. And this research needs to be supporting education, needs to be sound, and really based on representative samples. And to date, there are very few programs which are dedicated to educating these providers on medicinal cannabis. And if I could just turn to my colleague, Dr. Jennifer Ross, she was going to talk through the next slide, and we only have 3 more slides. Dr. Ross, if you could raise your hand.
Thank you, Elizabeth, and thank you all for having us speaking here today. Essentially, just strictly from a pharmacological perspective and really to tie together the clinical researchers and their providers that are actually writing the scripts. We need to better understand how much dosing wise each participant in a clinical study is consuming. So it presents a number of difficulties to both researchers and clinicians to not have sort of a sound idea of really the dosing that is being used by a particular patient and to try to control for that. One recommendation or idea to just start a conversation about this is to consider expanding the prescription drug monitoring program to include cannabis in a similar way that any pharmacy that you go to has a record and an identification of your prescription that your doctor wrote you. Why not hold dispensaries to the same level of accuracy in dispensing this medicinal drug? Finally, from a strictly pharmacological perspective, investing in high resolution drug testing would improve our ability to understand in the various ways that cannabis is consumed, how that drug is actually digested and how much of it is effectively working through the patient's body. So coming from a very quantitative perspective on trying to operationalize medical cannabis use, these are the things that we would recommend, or at least consider, invite you to consider. And I'll just turn this over now to our colleague, Dr. Robert Sterling.
Next slide, please. Thank you. My name is Robert Sterling, and I'm with Drexel University, and I'm very happy to be here this afternoon. You'll hear that there's a common theme throughout our commentary today, and it's about education and research. Before coming to Drexel, I spent over 30 years in the Department of Psychiatry at Thomas Jefferson here in Philadelphia, where I conducted both translational and outcomes-based research. And we remain in a situation, especially as we speak today about medical marijuana, we remain in a situation where limited research to date leaves both clinicians and patients alike uncertain about best practices to follow. And so what I'm going to advocate for, as Dr. Van Boxtel has and Dr. Ross has, is for more thorough and well-considered clinical outcomes research. The idea behind clinical medicine is to deliver the right care to the right person at the right place at the right time. And when we accomplish this, this sort of trifecta of events, ultimately we improve clinical outcomes, and that's the goal here. Unfortunately, we're not here yet, though, when it comes to medical marijuana. Much of what takes place right now is trial and error self-medicating in an attempt to find an efficacious outcome. If we're going to move the science forward, and we are going to move the science forward, we're going to need well-designed research trials that seek to match specific strains to specific clinical indications. And in that way, we'll eliminate the trial and error component of it, and we'll really create a science behind the diagnostics and the introduction of therapeutics. And in that way, a couple of things will happen. One of the things will effectively reduce the stigma around care using medical marijuana. and will result in a more informed clinical decision-making process, which is something I think we all look forward to. And with that, I will turn the floor back to Dr. Van Boxdale. Thank you so much.
Thank you. And this is just our last slide, just to reiterate our advocacy for the importance of educating providers broadly defined in a number of different health professions using evidence-based information. And we greatly appreciate your time today. That concludes our comment.
Thank you very much to all three of you. I'm very happy that you were able to join us today. I want to open the floor for any questions from the board regarding the information that you all presented. I want to start by highlighting something that Mr. Sterling, you had talked about, and that was, the need for well-designed research trials that match specific strains with specific indications. Are there any particular criteria or qualities of research trials that you think the commission should be paying particular attention to when evaluating whether something is sufficiently well designed in your view?
Thank you very much for the question, a very well-considered question. Ultimately, we have kind of landed on the randomized controlled trial as the sine qua non of evidence-based research. And I think that's ultimately where we would like to take the science, where we're doing prospective research, where we are employing very carefully considered inclusion and exclusion criteria so that we can eliminate as many extraneous variables in the decision making when we have positive findings. That would sort of be my answer to the question, Madam Chairwoman.
Thank you very much. Any other board members have any questions?
A brief
Madam
question.
Chair.
Go ahead.
I defer to Commissioner Nash and Vice Chair Delgado if they have questions.
Thank you, Commissioner Barker. Dr. Sterling, in the treatment community, and when you talk about opioid use disorder, we've heard on public comments here how cannabis has helped people who struggled with opioid use disorder. And I've personally spoken to people who have said that cannabis helps them tremendously. And I do find that there is this stigma with the treatment community where they are, there's one school of thought that says you must be abstinent and you cannot use cannabis. And then we find this other school of thought where there are people that are saying it's helping them.
Mm-hmm.
And I wondered if you could just shed some light on your thoughts on that and your experience.
Thank you for the question. It's fascinating to me that one of the single most cited articles that Dr. Van Boxdale and I have collaborated on over our time together doing translational research was a study where we actually looked at in a clinical population. I ran a methadone program, or was associated with running a methadone program, an opioid replacement program for over 30 years. And we saw a very potent and very robust effect with individuals when they were coming into treatment, which is a period of high stress for someone who are making tremendous changes in their life. And we found that individuals who were self-medicating with cannabinoids, and this was by urinalysis, confirmed by urinalysis, had a much more efficacious process of engaging in treatment and were more likely to still be in treatment at a period 6 months later. This is a positive outcome. The problem, of course, is there was no randomization. These were self-selected individuals. So there's a very strong signal there, but we can't definitively say. So this is why I'll keep circling back to the point that the degree to which we can conduct well-designed trials, the better off we're going to be at creating an evidence-based practice around medical marijuana. I hope that answered the
Yes,
question.
it does. Thank you so much.
Commissioner Barker.
Thank you, doctors. Thank you all for your time. We definitely appreciate it and don't take it lightly. Just a few questions, and I'll take my last question for you, Dr. Sterling. And thank you for stressing the need for well-designed trials. I know here in New Jersey, we have a clinical registrant component of our industry that we're looking to onboard in the near future. We are the pharma capital. And so one of my questions is, to your point about the research currently being limited and the need for more well-designed trials, this is for you and any of the other doctors and professors on the call. What does an equitable research trial look like? How do we engage in research, R&D, and the like, and create these well-designed trials in an equitable and safe and inclusive manner?
First answer is thoughtfully, and usually with the cooperation of an advisory board and a community engagement strategy, which is specifically designed at bringing individuals who are sort of historically misrepresented in these sorts of projects and brings them to the table, overcomes their reticence and reluctance, quite often very reasonable reticence and reluctance to participate, so that we actually have a picture of efficacy that really is generalizable, because ultimately that's what we're looking for in any kind of scientific enterprise, is we're looking for results that are generalizable that clinicians will actually put into practice.
Yeah.
And I'll toss it off to either Dr. Ross or Dr. Van Boxdale if you guys would like to offer a thought.
Nothing to add, Dr. Sterling, very well said, and thank you for the very thoughtful questions.
Absolutely. And just one last question, if Dr. Ross doesn't have a comment on that. It would, and I think Dr. Van Bakken said, you touched on this earlier in your outro, the need for more effective education and research. And I think you touched on the endocannabinoid system, one of the basic components of cannabis that's so critical for all of us mammals. And so at a basic level, I just wanted to ask, and again, any of the three can answer, how can we be better educators on the endocannabinoid system, and what grade or what age should be the cutoff for teaching about the endocannabinoid system, so we are properly educated and informed on this?
I can start. I think the earlier the better, in the sense that it's all in the delivery of how this material is presented. I'll just hearken back to some of the work that I used to do on a voluntary basis during what is called Brain Awareness Week. And we used to partner with the Franklin Science Museum and basically deliver a lot of content on how the brain functions. And we had a lot of middle schoolers, elementary age kids coming through. And really, these children are, depending on the manner in which you share the topic, are really sponges and really ask such thought-provoking questions. And again, if presented in an engaging and way, because a lot of times with the endocannabinoid system, I parallel it to our endogenous opioid system. So, it's even more abundant in our brains than the opioid system. So trying to explain, how neurons signal one another. You can actually use games in order to show that. I think the sooner we do this, the better for our children to understand. Jen, I don't know if you have anything to add to that.
Yes, I was just going to say that in terms of the clinicians that we are looking to engage today, I think that there should be an emphasis on, postgraduate or even in college, when individuals are taking their, registered nursing courses, or there needs to be a curriculum kind of baked into their training that includes cannabinoids, because as Dr. Van Boxtel was mentioning, the endogenous cannabinoid system is widespread throughout the brain, and in fact also interacts quite closely with the stress system. And so I guess I wanted to make two separate comments. One on the level of the education for training clinicians, and in doing so would kind of promote and empower and increase confidence in the clinicians that are looking to promote cannabis and its beneficial effects. And then the second, I would say, in terms of really having an equitably designed research clinical trial, what we have seen in our research relating back to the stress system, it really emphasizes the need to better understand cannabis, its benefits, and its uses in underserved populations. So just to kind of reiterate some of the points that have already been made, I think it's extremely important to continue looking at the stress system in relationship with the endogenous cannabinoid system and how that affects society in a systematic way as well. Thank you.
Thank you very much. Thank you all very much. Much appreciated.
Thank you. And I've got, I have one more question for, I believe it was Dr. Ross. You mentioned, or you suggested that the state should consider expanding the prescription drug monitoring program to include cannabis. From a practitioner or from a dispensing perspective, what do you think that should look like?
So, I mean, I think that, earlier you all were talking about Salesforce. It really needs to be kind of something that's implemented technologically, something that is connecting all the dispensaries, and kind of the prescriptions that are made on file, so to speak, and the filling of those scripts, right? Like, let's treat medicinal marijuana the way we treat any other pharmacological intervention. This would help standardize a few things to start, but I don't know exactly what that, implementation would look like, but I think it would have to be a system through which all dispensaries can kind of log in and be cross-checking for reference how individuals are filling their scripts, how often, what strains they're using, and for what indications. I mean, all of this information can be incredibly helpful from a research perspective.
Very much. Are there any other questions?
I have to agree in terms of how important the prescription drug program is for us to include cannabis. And a question that I have is, so I've done some of that work when I was at the Department of Health, and how opioids, how we track the amount of opioid usage in the state of New Jersey. Do you have an example of any state or any other jurisdiction that is doing this at this point in time that you could point us to?
Am I muted?
We can hear you.
Oh, you can. Okay.
Yeah.
To the best of my knowledge, the answer is no. And it's sort of, as we were looking over the topical questions in advance of today, it was sort of a light bulb went over our heads simultaneously, that wouldn't this really help standardize the process? So I don't know what it would look like. And, the problem with PDMPs, across the board is they're only as good as the people putting data into the PDMP. So that's one of the things I think the board should be considering very carefully if that's something that the board thinks might help with the standardization of care, is some sort of, monitoring program. Is what would it look like? What would it look like? And who's entering those data? I think that might maybe help a little bit with clinician stigma around involving themselves in delivering medical marijuana care.
I think if I could just add one more point, that I think ultimately the goal, anybody that's working in research in cannabinoids, the goal is to really demonstrate with really sound, well-designed clinical research the benefits of medicinal marijuana, and moreover, to guide patients away from options that may not work as well for them, so that we know exactly what we can direct someone with chronic pain or some other stress-related disorder, what strain might work best for them. But the goal ultimately is to build up enough evidence to have insurance companies have to pay for such interventions. By increasing the research and making it a bit less observational in nature and more intentional, and by building, I think, kind of an arsenal of resources, tools that not just the clinicians can use to increase confidence and direct their attention, but then also providing that I guess material basis to promote and to argue that this is a medication that is helping people, and people may in fact need help paying for such interventions, and that this should be treated on an insurance level as a therapeutic that should be considered covered. So I think that standardizing things in this way would also promote other aspects of patient care as well.
Thank you. Last call for any quick questions for this, our first panel of guests. Seeing none, I want to thank the three of you again, Dr. Van Boxdale, Dr. Ross, Dr. Sterling, for your participation and for your thoughts and insight here. I'll turn it back over to Director McWhite to call on our next invited speakers.
Thank you, Madam Chair. The next is Ken Wolski, and I believe you are free to speak.
Thank you. My name is Ken Wolski. I've been a registered nurse here in the state of New Jersey for 48 years, and I'm Executive Director of the Coalition for Medical Marijuana New Jersey, an organization I co-founded 21 years ago. I appreciate the opportunity to address the CRC on these issues, including qualifying medical conditions for the medicinal cannabis program. Regarding that, I urge the CRC to allow anyone with prescriptive privileges in New Jersey to recommend cannabis therapy for any condition that the prescriber feels may be helped by medical cannabis. Leave this up to the prescriber to act in the best interest of the patient. The state's already approved numerous medical conditions as qualifying for cannabis therapy, so therefore cannabis should be allowed to be recommended off-label, as it is in the case with prescription pharmaceuticals. Adding individual conditions to the medicinal cannabis program is time-consuming and inefficient. And also consider rare and orphan diseases. There are over 7,000 rare and orphan diseases, and one of them, Tourette's syndrome, finally qualifies for medical cannabis in New Jersey, but it took 8 years to qualify. But in another level, it really doesn't matter what conditions qualify for medical cannabis therapy if a patient can't get it because of their living situation. Currently, Most healthcare facilities forbid the use of medical cannabis in their facility, and this is dangerous, promotes needless suffering, and is potentially a fatal situation. And also, it is my sincere hope that the state will recognize its responsibility to institutionalize patients in New Jersey. For 25 years, I worked as an RN in state institutions, and I know that many patients in these institutions qualify for medical cannabis, could benefit greatly from it, and would reduce the cost of running these programs. The staff is already trained to account for controlled substances, and there is no reason to withhold this important therapy from these patients. Regarding research, there are currently about 80,000 patients and caregivers in New Jersey's medicinal marijuana program, and you've been providing medical cannabis to tens of thousands of patients every month, and it seems like you never ask how they're doing on this medicine. Well-designed clinical trials is a wonderful thing, but it would take years to finally complete, and a simple questionnaire could be developed in the meantime and sent to every patient as part of this program. The questionnaire would be voluntary, of course, and anonymity would be assured, and it would provide great information about what dosages and methods of administration are being used for what conditions and how effective it is. Are the patients experiencing side effects? Have they reduced their use of opiates or other medications? And have they experienced drug interactions? If the CRC doesn't have the resources to conduct this research, perhaps it can be farmed out to a local university like Rowan University or Stockton University that have research programs. And finally, with healthcare provider access, with few exceptions, there's a great deal of ignorance and a lack of interest in the physician community about medical cannabis. The American Medical Association has refused to endorse any of the medical marijuana programs in the 38 states that have these programs. And only about 6% of the doctors in New Jersey are taking part in this program. And oftentimes they make no specific recommendations about strains to use or methods of administration. And this information is more reliably obtained from bud tenders in the state's alternative treatment centers than from physicians. The CRC should quickly adopt dosing and administration guidelines and educational programs on the endocannabinoid system, as recommended by the J. Coney Law and the Department of Health's Executive Order Report number 6, Order number 6 report from 2018. Marijuana is mainstream medicine. Even the DEA appears to be on the verge of admitting that marijuana is medicine by reclassifying it to a Schedule III drug. So, and as more people experience the medical benefits of cannabis through the adult use program, healthcare professionals in the state must become comfortable incorporating cannabis use into the therapeutic regimens of their patients. And this can be done most efficiently by requiring education on the endocannabinoid system for all healthcare professionals with prescriptive privileges in the state of New Jersey as a condition for continued licensure in the state. That should get their attention. I mean, it is truly remarkable that an entirely new system in the human body was discovered a mere 30 years ago. And this system interacts with all the other systems in the human body. So no one can say that it doesn't affect them. ECS researchers say the system may well play a role in all disease processes affecting humans and animals. So thank you for this opportunity to address the CRC.
Thank you, Mr. Wolski. Are there any questions from the board? I'll start. Mr. Wolski, you talked about the ignorance, perceived ignorance within the medical community around these issues and around the endocannabinoid system, but participation and benefits of participation, benefits that can be realized by patients in the medicinal cannabis program. Do you have any ideas or suggestions for the commission to tackle this perceived ignorance?
Well, yes. I mean, my main suggestion is to require that there is education on the endocannabinoid system for all prescribers as a condition for continued licensure. If the American Medical Association would be educating itself about this this newly discovered system in the human body, and following the science. There would be a great deal of excitement about this. They would be requiring physicians to learn about it, because here it is. It's interacting with all the other systems in the human body. I mean, if physicians spend a limited who specialize in limited areas of the body say that this doesn't affect me, that they really can't say that, because it affects every organ of the human body, the endocannabinoid system, and receptors for cannabinoids, both the phytocannabinoids in the plant and the endocannabinoids that our own body makes. Receptors for them are in every organ of the human body. So it definitely, what role you might have in advocating for required education on the endocannabinoid system should certainly be used.
Thank you very much. Any other questions from the board?
Yeah, it's just a brief question. Mr. Walski, thank you very much. Again, thank you for taking time to join us. Thank you for your leadership in this space for the last few decades. I just want to circle back to the same question that was posed to the previous speakers, and being so entrenched in New Jersey, knowing that we are pharma capital, knowing that our industry is looking to onboard a clinical registrant component. What does equitable, inclusive, and safe research look like in New Jersey? How does the pharmaceutical industry enter this space when it comes to research and development in an equitable manner? Would love to hear your thoughts on that.
Well, that's a really good question, Commissioner Barker. And part of the problem with doing cannabis research and developing clinical trials, especially if you're mimicking the pharmaceutical model, is that they typically go with single substance research. So rather than a complex plant like cannabis that has hundreds of cannabinoids, or at least 100 cannabinoids, and hundreds of other components to the plant. So to try to try to design even clinical research is a difficult problem. First of all, it starts with some small scale clinical trials have been completed. No, not a single large scale clinical trial has ever been completed in the United States on cannabis, partly because the federal government's resistance to this. So it's tough to work it into the pharmaceutical model that is the model that we have for approval for drugs, and so I look for other experts on the actual research to give you some more information about this. Gaetano Lordieri is one of the board members of CMMNJ, and he's going to be talking about this a little more later. It's the research that I suggested was just again a expansion of the observational research to be providing tens of thousands of patients with medical cannabis and not asking them how they're doing is just a wasted opportunity for gathering more information while we wait for the clinical trials to be completed. And if it follows the pharmaceutical model of clinical trials, these clinical trials are going to take years to complete. So we can get more information, valid information, sooner. And regarding the insurance coverage, insurance coverage is, these state programs that the state funds, they've already passed through some of the, we have bills in the legislature right now to provide for insurance coverage for medical cannabis for various programs. And some of them have passed through legislative hearings already. So, you know, we can provide that already here in New Jersey with the information that we have. I hope I answered your question.
No, thank you. Yes, you did. Yes, you did. And absolutely did. And probably look forward to following up with you down the line for more information. But you did. I think what I gleaned from that, if I may, and correct me if I'm wrong, but the current frameworks, like a lot of things in cannabis, the current frameworks may not be working. And so it's an opportunity to revisit the status quo and see how we can rework it or tweak it or change it for the better to make it more inclusive and more equitable.
Yes, absolutely. Thank you, sir.
Thank you.
Thank you. Are there any additional questions from the board for Mr. Wolski? Seeing none, thank you again, Mr. Wolski, for your insight and your experience, sharing your experience with us here today.
Thank you.
All right, I am going to call the next 3 invited speakers. So if you can raise your hands for us, I am going to allow you to talk, but please remain on mute until you are called upon to go ahead and start speaking. So I do see Nichelle Santos and Gaetano Lardieri from New Jersey for Minorities for Medical Marijuana. I do see Dr. Alex Becker, Chairman of Medical Marijuana Review. I also would like Leo Bridgewater for Service Disabled Veterans in Cannabis to please raise his hand, and Edward Lefty Grimes from Sativa Cross to please raise his hand as well. Again, we will start with Nichelle Santos and Gaetano Lardieri, and then Dr. Becker, and then Mr. Leo Bridgewater. Please, again, please state your first and last name and your affiliate organization.
Hello, can you hear me?
Yes.
Hi, this is Gaetano Lardieri. Just want to wish everybody a happy Pride and Juneteenth. So good afternoon, Chair Waino and esteemed commissioners. I am very honored to be invited to speak before you today on a subject that is close to me, both professionally and in my role as a New Jersey State Co-Director for Minorities for Medical Marijuana. That subject is research. My name is Gaetano Lardieri, Co-Director for Minorities for Medical Marijuana, New Jersey, M for MM. I served in this role alongside my colleague and friend, Nichelle Santos. I'm also a board member of the Justice Foundation, Coalition for Medical Marijuana, New Jersey, and UPenn's affiliate scholars, all of which are supporters of safe, efficacious, robust cannabis research. Nichelle and I have served in this role for several years now, proudly advocating for social equity in the cannabis industry, and now strongly advocating for the same when it comes to building out a cannabis research program. I've spent 40 years in the medical field, including 26 years in cancer research. I have led teams to significant achievements, such as an FDA approval for a breast cancer drug. For the past 11 years, my focus has shifted to alleviating the stigma around cannabis and psychedelics and advocating for research. I commend the CRC for your outstanding work in fostering social equity within New Jersey's cannabis industry. Now it's time to elevate our efforts to the next level by supporting and building a robust research program. New Jersey has a unique opportunity to lead in cannabis research by leveraging our state's exceptional talent and the strong foundation and framework already established by the CRC for social equity. I propose creating a dedicated division within the CRC for cannabis research. This should be a separate chair led by an expert specifically with experience in cannabis clinical trial research to ensure complexity and safety are managed effectively. This division would include high-level professionals and advisors to guarantee patient safety and regulatory compliance. The vision should encompass building a state-of-the-art research program that not only advances the scientific understanding of cannabis, but also reinforces the principles of social equity that the CRC has championed. By incorporating scientific advisors, policy experts, and minority and indigenous representatives at all levels of research and clinical trial participation, we can ensure that such programs are inclusive and representative of the fabric of all New Jerseyans. Our medical community and schools must be incentivized to participate, helping to educate and eradicate stigma. This starts by implementing a robust curriculum in our medical schools to include curriculum on the endocannabinoid system. This also extends to developing a vigorous campaign to educate and bring awareness to the general public of the endocannabinoid system. Implementing these two criteria as soon as possible is crucial in building a strong foundation for research, development, and an educational system for cannabis. Imagine New Jersey, a beacon of innovation in cannabis research, setting standards that other states aspire to follow. We have the talent and the resources to make this vision a reality. Our research should address and guarantee safety, efficacy, and accessibility for all, establishing a well-developed and comprehensive clinical registrant application license and guidelines with industry inclusivity in mind at all levels will formalize this process, allowing physicians and other healthcare professionals to study cannabis for various conditions and lead to many questions being asked and answered. We must also develop protocols for patients using cannabis during hospitalization and explore its potential as breakthrough therapy for our veterans and those who need end-of-life care. To gauge public opinion and healthcare provider perspectives, conducting surveys will be beneficial. Additionally, research can and should explore the question of impairment, home grow options, and help create standards. Well-designed clinical trials can provide answers to these and other critical questions. Research must always focus on social equity progress, ensuring transparency and communication about ongoing studies and results. We must implement systems that can measure progress and report the progress to the general public. Data is the new gold. And we in research always say, in God we trust, all others bring data. By addressing the legal stigma, related barriers, New Jersey can create a state-of-the-art cannabis research program that sets national standards. In conclusion, let's embrace the opportunity to advance cannabis research in New Jersey, ensuring it's conducted fairly, inclusively, and transparently. Together, we can reveal the plant's full potential to the benefit of all New Jerseyans and beyond. And I thank you today for this opportunity to speak before you.
Thank you very much. And I know we have Nichelle Santos here as well. Ms. Santos, did you have any other remarks that you wanted to share before we open up the questions for
Yes.
MM? Yes, go ahead.
Good afternoon. I'm Nichelle Santos, New Jersey State Co-Director of Minorities for Medical Marijuana of New Jersey, board member of the Coalition of Medical Marijuana of New Jersey, and founder and CEO of Canna Coverage Insurance Services. We stand on the pillars of social justice, social equity, health equity, and creating good policy to alleviate the stigma of medical cannabis. I greatly appreciate the invitation to provide testimony before the New Jersey CRC to develop updated regulations for the expansion of the current list of qualifying medical conditions impacted by the use of medicinal cannabis. This is a historical moment in the end of prohibition of cannabis, the 14th anniversary of the legalization of the New Jersey medical cannabis program, and now hopeful in the federal reclassification of cannabis from Schedule 1 to Schedule 3. New Jersey can transform healthcare and lead the country with a viable path to achieve health equity in all communities, and especially communities with high levels of conditions and illnesses from social determinants of health. By bringing plant-based medicine to healthcare as an alternative to opioids and other highly addictive drugs, of which cannabis has much fewer adverse side effects. Medical cannabis can improve health outcomes, increase workforce productivity, and as the cost of healthcare continues to rise, medical cannabis benefits is now available to employer-sponsored health plans, bringing substantial cost savings. By expanding the New Jersey medicinal cannabis program, we can bring medicinal cannabis patients back to the declining program to maximize the health and wellness of patients who benefit from the use of medicinal cannabis, to include any other chronic or persistent medical condition that is not specifically listed, as long as their physician recommends it, to provide greater access to this therapeutic option. More patients can experience relief from their symptoms as they do in the state of California. I'm requesting the CRC to consider the following steps for expansion of New Jersey medical cannabis program. Number one is to support physician education to build the network of medical cannabis doctors who can properly diagnose and recommend strains and terpenes that may have the ability to effectively replace prescriptions. Education will develop with clinical research with evidence-based data. Number two is engage healthcare carriers to increase patient access to medical cannabis with the creation of new CPT billing codes. So current procedure terminology is the language spoken between providers and payers for reimbursement of care and the gateway to increase the network of physician participation for medical cannabis patient visits. So patients pay their copay for doctor visits and the doctor gets paid by the carrier. Number three is medical cannabis should be a reimbursable benefit, just like any other prescription drug covered under a prescription plan. This plan will be bolted on to core benefits of employer-sponsored health plans to increase patient access and affordability. Patients should not have to pay for medicine out of their pocket, including medical cannabis. So patients pay for their copay, for their purchase, and the dispensary gets paid by the pharmacy benefits manager. Number four is initiate a study of prescription drugs that can be replaced by medical cannabis, such as anticonvulsants, antipsychotics, anti-migraine, anxiety, antidepressants, opioid pain meds, muscle relaxers, ADD, ADHD medication, sleep medication, medicated skin ointments, glaucoma meds, and much more. Bring HIPAA compliant science and innovation to give power to patients. We have DNA test kits to identify biological predispositions of conditions and illnesses, to take the guesswork out of diagnosis and increase the efficiency of recommendations of terpenes and strains, as well as other prescription drugs. This process will increase health and wellness of patients in New Jersey and across the country. So Canna Coverage Insurance Services is leading with technology, science, and innovation in healthcare with strategic partners to scale transformation through the masses of group health benefits of both private and public entities. We'll decode DNA and genetic predispositions for better diagnosis and treatment, and transform access to medical cannabis with a national cannabis physician network and dispensary network to integrate medical cannabis into traditional therapeutic healthcare models. And the following are three legislative bills specific to health insurance carriers here in New Jersey for medical cannabis. The first is S1943, requires workers' compensation, personal injury protection, and health insurance coverage for medical use of cannabis under certain circumstances. Next is A898, establishes a program to subsidize purchase price of medical cannabis for registered qualifying patients enrolled in Medicaid or New Jersey family care programs. And finally, S1944 allows costs of medical cannabis to be reimbursed by catastrophic illness and children relief fund, PAAD, and senior gold. So I can stop there or I can keep going.
I think that's probably a good stopping point for now. Thank you so much, Ms. Santos. Are there any questions from the board for Mr. Lardieri or Ms. Santos?
Just a brief question, Madam Chair, for Mr. Lardieri.
Yes, Commissioner Barker.
And thank you both, Mr. Lardieri, Ms. Santos, for your comments and your leadership on this front. Mr. Lardieri, you touched on, and correct me if I'm wrong, but I believe you mentioned that you've been through the FDA process and you've worked and had a drug approved. Could you go through what that is like, getting FDA approval? If you can you speak to the stages of review? I think Mr. Walski was touching on stages 1, 2, and 3, which are more observational, versus stage 4, which gives the person being tested some input on how the test is going. Would you be able to just touch on that FDA process and your thoughts on how we can make it more equitable, or any tweaks that can be considered specific to cannabis?
Yeah, can you hear me?
Yes.
Yeah, thank you for the question. So the FDA process is very complex and very expensive. And yes, pharmaceutical companies do concentrate on single molecules, but research encompasses lots and lots of things, right? So real world evidence. I mean, we touched upon a little bit earlier. We can go out there and do surveys and see what's going out on the real world. We can engage one of the universities to do a survey or observational study. Those are very, very important. So other than just single molecules, which pharmaceutical is going to do what pharmaceutical does, and they're going to cut out their lane, but it's not always just single molecules that we focus on. We can do other kinds of studies that focus on social equity and observational studies that are very, very important. So I would say we can concentrate on those as well and get funding for them and get those through the process as well.
Thank you very much for that. And if there's any info or material that you want to send over, please feel free to share it.
Yeah, the important thing, in my opinion, is the CRC needs to build a division that is inclusive and of experts on all levels, scientists and participants. So that's very important, and hire an expert that can manage that division as well.
Okay. Thank you very much for that.
Thank you.
Thank you. My question is for Ms. Santos. As an individual who is directly involved in providing coverage for medical cannabis, I would like to hear a little bit about what barriers or challenges there may be for businesses to or health carriers to incorporate medical cannabis into their coverage options.
Thank you for that question, Madam Chair. We have engaged with conversations with medical carriers, and they are becoming more receptive to the conversation. Of course, we always have to overcome the stigma that cannabis brings. Leading the charge with medical cannabis and an evidence-based conversation, we are now directed towards conversations where we can discuss the efficiency of replacing prescription drugs with medical cannabis, right? So correlating specific conditions where employers are spending high dollars on those specific claims, and then doing a study on the replacement of those prescription drugs is what employers are interested in, what the healthcare carriers are interested in. Always follow the data and follow the money. Am I answering your question?
Yes, thank you very much.
And let me just add that it's more about the process in the creation of the CPT codes. The doctors have to engage, but they can only engage if there's a way for doctors to be paid for the patient visits. So the development of the CPT codes, and then the development of the process and engaging with the pharmacy benefit manager who controls the prescription plans. So those are the plans, the processes that we're currently working on with healthcare carriers. But including the CRC in the conversation just gives us more ammunition. So thank you.
Thank you. Any other final questions, Commissioner Del Cid?
Yes, thank you, Madam Chair. Well, thank you to the speakers today and both of you for your comments. When you said health equity, it was like music to my ears. So thank you for that feedback. One clarifying question for Ms. Santos. You mentioned HIPAA, but could you elaborate exactly on that? I may have missed what you said on HIPAA related, but it definitely caught my ear.
I brought up HIPAA to bring HIPAA compliant science and innovation to give power to patients. We have HIPAA compliant DNA test kits to identify biological predispositions of conditions and illnesses, to really take the guesswork out of diagnosis and increase the efficiency of recommendations of terpenes and strains, as well as other prescription drugs. And this process will increase health and wellness of patients in New Jersey and across the country.
Got it.
So be HIPAA compliant with those DNA test kits. We can be HIPAA compliant in aggregating data from private entity or public sector entities when we look at high claimant conditions and illnesses and how it can be impacted by medical cannabis. That study will be HIPAA compliant.
Okay, perfect. Thank you.
You're welcome.
Any other questions? Oh, Vice Chair Delgado, I believe you're on mute.
I need to take myself off mute. So I have a question. So, and I'm a simple guy, liberal arts major. I really don't understand all this clinical stuff. But are you saying that if we migrate over to the migrate cannabis to insurance, that my insurance policy is going to be lower? Is that I'm going to save on my health benefits?
We look forward to the day when your insurance ID card not only includes medical coverage, prescription plan, dental, vision, but also medical cannabis. We will increase the network of cannabis physicians in New Jersey and increase the network of dispensaries, medical dispensaries, so patients can have increased access and affordability.
That's not the question I asked. The question I asked is it going to lower my premiums, my medical premiums?
That is always the goal, because as we all know, insurance increases every year. So we're always striving for cost saving strategies. And by having this alternative to medical cannabis, as opposed to very expensive prescription drugs, we do have case studies we can share, and we'll provide that in the written testimony.
And if
those case studies show the lowering of and the reason I ask is because I'm a senior citizen. I'm concerned about my premiums, and so those studies show that the premiums, insurance premiums, would go down.
It doesn't impact the aggregate of the insurance premium. The case studies illustrate the cost savings to the employer, right? And if this employer is a member of the public sector, this can have an impact on lowering our taxes here in the state, because we're lowering the cost and replacing prescription drugs, expensive prescription drugs, with medical cannabis.
And if I may jump in, this is a place where research and a study, instead of just case studies, right? We could design a program around to measure. You always want to measure your progress. So this is a great area where we can measure that progress and then see where the insurance premiums could be lowered. So there's your argument for a research study.
Well, I agree on the research study. The only challenge, and again, I'm a liberal arts major. I'm just a simple guy trying to make sense of this. And I want to be educated. I understand. I'm all for the clinical studies. I think that's very important. But you still have an illicit. You still have a market out there that's not legal, right?
Right.
So how do you capture that in your clinical studies? Because you got lots of variables here. And in clinical study, this is the scientific method that I learned in 8th grade.
Yeah.
So you're doing clinical studies with the legal cannabis, but you still have this whole world out there of not legal cannabis. So how do you do the clinical studies like with that? How do you take care of those variables?
Well, we can really transform healthcare by incorporating medical cannabis into your employee health benefits.
But that's not the question I asked. That's not the question I asked. I'm talking about. I'm not talking about incorporate right now. I'm not worried about. This is a different question, and the different question I'm asking is, you mentioned clinical. How do you conduct the clinical studies with, you still have that other marketplace out there, the legacy market.
Well, there are ways of capturing real, like I said, real world data. You have to go out into the community and collect those data and measure it. So there are ways of capturing that in a well-designed real world data trial or clinical research.
That's challenging, don't you think?
Yeah, of course.
And I'm not saying I'm not against clinical. I'm all for it. Believe me. Yeah. I'm just trying to bring out the challenges that you would have. That's all.
Yeah, it is challenging, but it could be done, right? And with a well placed program, this could be done. And then, as Nichelle said, if once we can get this up and running and show good measurement on people coming off of opioids and so on, that probably would cut into the other markets. You see what I'm saying? Do you understand?
It's still, you haven't solved it. It's still a challenge.
Well,
it's a challenge, but it's not impossible.
Yeah, there's always
I don't think
engagement.
anything's impossible, but yeah. The other issue, it's not an issue. It's not. I guess it's another challenge that I see, and that is if you, and I can see this happening because human nature is human nature, right? If you do the insurance thing, in other words, if you allow cannabis into the insurance world and insure it, don't you think that people will just gravitate towards getting insured?
Well, we're bringing medical cannabis to employers.
Get a lot of people migrating from the adult use to the medical because they don't have to pay. The insurance covers it.
Right, which would be beneficial to the medical program here in New Jersey. Right now, the membership is declining month by month.
Exactly.
So by incorporating medical cannabis into employer-sponsored plans is a way to scale patient access and patient affordability, and it gives you a way to track and measure health outcomes. So right now, we can aggregate data for the high claimant conditions and illnesses and do a cross correlation of how medical cannabis could have replaced specific drugs and do that cost benefit analysis, right? And then as we
is there a current cost benefit analysis that you just mentioned?
There is a cost benefit analysis hypothetically, but taking real live data from an existing public or private entity and doing that cross correlation can be very beneficial. We're actually talking to a public entity about conducting that study.
And that's what you want to show. You want to show positive health outcomes, right? And then once you start showing those data, now you have some real information you could deal with in programs you can start implementing.
Yeah, Madam Chairman, for the sake of time, I'll yield my time back to you.
Great questions.
Because this conversation, this is a greater conversation to have. I think everybody agrees.
It's complex, but it could be done.
Absolutely.
Agreed.
Thank you for the questions.
Yeah, thank you.
Any last quick questions for these two guests? All right. Hearing none. Thank you, Mr. Lardieri and Ms. Santos, for your thoughts, your insights, and your recommendations that you've shared with us today.
Yes. Excuse me, sorry. Next on the list of speakers is Dr. Alex Becker, Chairman of the Medical Marijuana Review Panel, and the rest of our invited speakers have raised their hands, but Chris Goldstein, I do see you. Can you please raise your hand as well? Thank you so much. Dr. Becker, it's all yours.
Yes. Can you hear me?
Yes.
Yes. As previous speaker mentioned, there are well-documented evidence that cannabis help people with various conditions. Our panel, which I chaired, approved marijuana or cannabis, better use the word cannabis, for 17 conditions, including reduction of harm associated with substances like alcohol, opioids, stimulant, including people with high risk for overdose. So what are the obstacles? And again, previous speakers mentioned in one way or another. I was just to summarize for the sake of time. There are 4 key themes: lack of medical cannabis education within healthcare community, misconception and misunderstanding that perpetuates stigma towards medical cannabis, lack of guidelines on cannabis doses for various indication, and access to medical cannabis. I will just comment on the first 2. There are several studies that indicate that approximately 80% of healthcare professionals in training feel that they lack sufficient knowledge to make recommendations regarding medical cannabis. Thus, incorporating medical cannabis education into medical school curriculum and providing evidence-based guidelines can increase physician confidence and comfort in authorizing medical cannabis. Same applies to other healthcare professionals, of course. This educational gap indicates a need for standardized medical cannabis curricula and could be added, and this is important, could be aided by acquiring cannabis knowledge in licensing examination. I think Mr. Walski mentioned this as well. It should be part of licensing exam. Cannabis therapists may also benefit from public education and destigmatizing strategies such as those previously been used in fields like HIV and AIDS. Lack of consensus among healthcare professionals regarding harm reduction with medical cannabis is additional problem. A second major impediment is a lack of guideline on dosages and regimen of cannabis for various medical conditions from any professional or governmental body. Again, this point was taken by first 3 speakers. Thus, I believe it's one of the critical steps is to important step is to establish a registry of current practices and establish group of professionals that will issue best practices guidelines. We do have registry in New Jersey, but it's more administrative registry. This registry, which I propose, should include actual time course of a disease, what it was done, and we can create this register by collecting data from currently licensed professionals. And then you can panel, some medical panel, which includes other health professionals, will establish guidelines, which again, it reflects points which we brought up before by Dr. Sterling. It should be clear recommendation and expand. I don't know, right now we have 17 conditions, we can expand, but this is secondary. Even for this 17 condition, we don't see no clear guidelines what to do, and we can ideally it's on a national level, but enough information here to put it together in some registry in New Jersey and issue some type of guidelines, which will help with all other issues with insurance and everything else, because guidelines would be critical in this path. So in the sake of time, I will stop right here. If there are any questions, I'll be obviously happy to answer.
Thank you so much, Dr. Becker. Any questions from the board for Dr. Becker? Commissioner Barker, it looked like you were about to jump in.
No question right now for Dr. Becker at this second, but I might change my mind in the next few seconds. But right now, I don't have any.
Thank you. All right, hearing no questions for Dr. Becker. Dr. Becker, I want to thank you for taking the time to to join us and share your thoughts and recommendations with us today.
Thank you. Thank you.
Up next is Leo Bridgewater from Service Disabled Veterans and Cannabis. You can go ahead.
Good afternoon, everyone. My name is Leo Bridgewater. I am co-founder of the Service Disabled Veterans and Cannabis. I also sit on the Social Equity Committee for the National Hemp Association and was a former National Director of Veterans Outreach with Minorities for Medical Marijuana and co-founder of Collective 60 New Jersey. I wanted to talk about the expansion, observations and suggestions that I have regarding the New Jersey medical marijuana program. And I have to be honest with you, it was a really good treat to hear Dr. Becker speak when he was part of the New Jersey Medical Marijuana Review Board. We actually gave testimony to have PTSD added as a qualifying condition. So it's great to see and hear him speak today. That being said, on June 4th of 2024, just a couple of weeks ago, the House, the United States, the United States Congress passed I'm sorry guys, I'm trying to pull this up on my thing here. The House passed a veterans focused marijuana and psychedelics amendment out of committee to go before the Senate in anticipation of cannabis going from Schedule 1 to Schedule 3. My recommendation would be for the New Jersey Cannabis Regulatory Commission to start talking to the New Jersey Senate Military and Veterans Affairs Committee, which is chaired by Senator Gordon Johnson. And members are Nilsa Cruz Perez, Raj Mukherjee, Senator Raj Mukherjee, Senator Parker Space, and Senator Latham Tiver, to talk in anticipation of, cannabis going from Schedule 1 to Schedule 3, so that we can begin that informal education process. We often talk about access to the plant, to the medicine, as being a one of the barriers when it comes to dealing with veteran access. And so I think in having these preliminary conversations, since this is going on, I think would be very key. I also have traveled all across the country speaking to these types of things when it comes to veterans. And I will tell you that when it comes to the VA is broken up in a number of different sections. Like, because I live here in New Jersey, I'm in Zone 4 for the VA healthcare system. But I do know that Zone 21, which is the Pacific Southwest, which includes Oakland, California, actually has they actually do make recommendations. The VA doctors do, because they are much more versed in all things VA when it comes to cannabis plant, to include yoga and so on and so forth. And so to have uniformity within the VA healthcare system begins with that education and seeing that it goes from Zone 1 all the way into Zone 24, which is what the VA healthcare system is made up of. I also think that, and from an observatory perspective, especially here on the streets, one of the things that we've had here, I live in the city of Trenton, and so the crime rate here is pretty high. A couple of summers ago, we had a situation where almost 200 summer jobs went unfulfilled by city teenagers and residents because they could not pass the drug tests, and they all were testing positive for cannabis. And so my suggestion to the county executive at the time, a man named Samuel Frisbee, was to have these teenagers enroll into the New Jersey medical marijuana program. It was going to allow them to be able to continue on with the job for the summer, and also because it offers different types of protection too, from dealing with the police and so on and so forth. and also to counter some of them, being prescribed opioids. And so from just a bare bones street level perspective, I really think that, having those kinds of conversations with the Senate Military and Veterans Affairs Committee, anticipating the Schedule 1 to Schedule 3 move. We hope that it'll be completely descheduled, to be quite honest with you. These are all things that I think that New Jersey can do in terms of taking a proactive approach to, expanding the medical marijuana program, and also from a social equity component for stakeholders such as myself and people who look like me or people of color. With that, I'm gonna make it. I want to try to make it quick, and that would be all I have. If you have any questions, I am available right now. Thank you.
Thank you very much, Mr. Bridgewater. Are there any questions from the board?
One brief question, Madam Chairwoman.
Yes, Commissioner Barker.
Mr. Bridgewater, thank you for your service, first and foremost, and thank you for your advocacy in this space over the last several years. Just want to ask you specifically, as somebody who has been instrumental in advancing different medicinal conditions to be included for patients, are there any that you think should be added? Are there any conditions that aren't currently being considered? And I do want to make light of Mr. Walski's comments. I do remember what he said in terms of just making a blanket for all conditions. But are there any specific conditions that you think should definitely be added in the event we can't do a blanket catch-all?
No, you know what? I would echo the same sentiments as Ken, as Ken Wolski has said, which is, all conditions, to be honest with you. But what I will tell you is that if you really want to increase veteran participation, something to think about would be to figure out a way where, you have veterans don't have to give up their gun privileges. I know that's beyond your scope, but it's something that needs to be talked about, because that is in of itself a very big barrier why you don't have a lot of veteran participation because of firearm privileges. That's something to think about.
Okay, absolutely. Thank you very much for that.
Thank you for your question, and thank you all for your service.
Thank you.
Any other questions for Mr. Bridgewater? I have one question with respect to the doctors in the VA program that you said out in the on the West Coast who are making cannabis recommendations. Do you happen to know or provide any insight on what information, what is most compelling for these doctors and these practitioners to make those recommendations, despite some of the challenges that they face at the federal level?
What's interesting, and thank you for that question, Chairwoman Waynu. What's interesting is that I was actually working with a colleague of mine by the name of Amber Centaur, who's co-founder of Supernova Women, and she actually moved literally all of her healthcare, anything strictly to the VA. She's a Coast Guard veteran. And the reason for that was because it was her VA doctor who was suggesting to her that maybe she ought to take a look at looking at the cannabis plant and all that it can serve for her, not knowing who she was. And so Amber did the thing where she just stayed quiet and just wanted to hear what the doctor had to say, and let this doctor go on and on about the benefits of cannabis and so on and so forth, which was, something that she had never heard and never thought was going to be a thing until she happened to had that VA appointment, and all these things came out. So it taught her that because she's in Oakland, California, a lot of the medical professionals there by proximity are a little more versed or more well versed than, let's say, the VA doctors who are here in New Jersey. You understand? So they took the time to really get to know all the plant, and including a lot of them are probably actually consuming cannabis themselves. So they have a rather intimate, she told me she felt as though they had more of an intimate relationship with the cannabis plant than what I would describe what my experience would be like here on the East Coast. I actually came out to my VA doctors back in 2015 that I was actually consuming cannabis, so that it was at least documented within my records and my charts, so that should I face any adverse repercussion from the VA, at least it was documented. And that actually happened to be the case for a lot of people who are in states that don't have comprehensive medical marijuana programs, and doctors who are not really all that well versed. And so if we can get to the point where now you have these, this is what's happening in Congress, and these bills that's going on, being that the conversation is something that's being talked about a lot. I think it's like one of those, let's strike while the iron's hot type of things, particularly when it comes to the veteran side of things. And with veterans, we kind of move mountains when you're talking about our healthcare.
Absolutely. Thank you so much. I appreciate that insight. Last call for some quick questions for Mr. Bridgewater.
I have one more, and I'm just gonna piggyback on the same question that I've been asking, and just get your specific thoughts on it, if you may, Mr. Bridgewater. Considering New Jersey is a pharma capital, considering we're working and on the cusp of our clinical registrant guidance and rules, and what does equitable and inclusive and safe research look like in New Jersey?
It looks like you're in my neighborhood talking to me and people who look like me and those who are considered trusted messengers. And so I believe that what you have to do is you have to start naming names like a Ken Wolski, like a Keith DaCosta of Care Spark. These are people who are accustomed to being in the neighborhoods, on the streets, the front line, sort of say, and actually talking to the people. Because right now, when you're talking to regular folks about medical and adult use, they're not making that distinction. They don't know to make that distinction. On top of the fact that you also couple the efficacy of cannabis use along with the illegality or the reverse of the illegality of the plant, it makes for people to be more welcoming and more receptive to the conversation. I also think you need to be in the churches talking about the medical efficacy of cannabis as well. There's a massive amount of public, education that still needs to take place despite all of the efforts over the years. If you really want to know what social equity looks like in the research and the efficacy of this plant, go where those people actually are and actually have the conversation. Right now, that's not what you're seeing, or at least hearing folks talk about. They still say gateway drug in a lot of places, here in New Jersey, and that's not even the case. And when you say adult use, they still bring up children. So there's a lot of things that are going on, particularly and from a municipal level as well. So that one conversation can literally spiderweb so many other conversations to include that would actually help to educate a municipality. And mind you, it's not just the people, but it's also the municipal governments themselves, like the city councils, like the mayors. These are all folks who still say the old things or subscribe to the old way of thinking when it comes to the cannabis plant.
Thank you for that. Thank
No
you very
problem.
much.
Excellent. Well, thank you again, Mr. Bridgewater. I want to echo Commissioner Parker's sentiments. Thank you for your service and your dedication to our country and to the issues that you shared with us today.
It is my honor, and thank you for all of your services too. Thank you.
And I'll turn it back over to Director McWhite to call on our next invited speakers.
Yes, the next invited speaker is Edward Lefty Grimes of Sativa Cross. Lefty, I believe you can speak now.
Good afternoon. This is Edward Lefty Grimes. I'm with sativacross.org. I'm a founding member of Sativa Cross. We're a 501c3 fighting for wheelchair accessibility around New Jersey, and for cannabis patients' rights. I have 4 things I'd like to speak about today, and one of them is the Zoom access, which I really appreciate this because I'm in a lot of pain right now. I have horrible sciatic pain. I'm in really no shape to drive an hour and 20 minutes to Trenton. And there's a lot of people in the same shape as me. And we really appreciate this because you're actually relieving my pain and suffering today. I can attend your meeting without the extra pain and suffering that I would normally endure. And Zoom access is very important. For disabled people, we've been asking for for Zoom access for years, for disabled access for work, Zoom access for school, for council meetings, for churches. And for 19 months, we were able to get those things. It wasn't done for us. It was done for healthy people so that they wouldn't become disabled. But for 19 months, disabled people enjoyed all those things. And then all of a sudden, after the pandemic was over, a lot of councils took it away. I don't know why they took it away. So I would go to these councils and ask them why they would take it away. And they said, well, we don't have the funds for it anymore. We don't have the people to do it anymore. We don't have the technology to do it anymore. And I'm just like listening. I'm like, wait, we did this for 19 months. Now we can't do it. And it's very important because my friend Jeff Oakes was able to take part from his deathbed, literally announced he was taking part from his deathbed. And I want to hear somebody, if they have something to say from their deathbed, I want to hear it. And I think you all should hear it too. And I think that's very important. My second point is, I know you're not going to like this, and we don't talk about this much anymore because you can't do anything about it, but you actually can, and it's home grow. I want to know why New Jersey is the outlier state and why we can't get an informational hearing since 2009. I think that the CRC should have an informational hearing. No voting, but just an informational hearing so that we can set an example and be progressive so that maybe the government will do something about this. Because my next point is going to bring up about wheelchair access. And I think that the CRC can be progressive in moving the ball forward with things like wheelchair access. Now, I've been talking about wheelchair access to the greenhouses of dispensaries for years. If a worker gets hurt, if a worker loses a limb, if a worker gets progressive MS and suddenly can't walk anymore and they're in a wheelchair, there's no light duty and they would lose their job. And when I was on the medical advisory board of TerraSend, I saw how the greenhouses were built and with no nothing for disabled people working in. It was just all made for money, as much money as you can possibly make. And I think that should be an issue. But then I was kind of shocked because I saw there was a bunch of dispensaries opening up without wheelchair access. And this is something I've been fighting for years. I've been all over the state. I've been to hundreds of council meetings, fighting for wheelchair access at police stations and post offices and pharmacies. And Chairwoman Waynu said something about encouraging dispensaries to get wheelchair accessibility. And I like that, but I think it needs to go a lot further than encouraging because we've tried to encourage our government to do these things and they don't listen. We've been to South Amboy Police Station. We set up a ramp at the South Amboy Police Station to show them that we can't get in and nothing was done. We went to the council meeting at South Amboy to tell them that nothing was done. And they told us that it's grandfathered in. We went to Senator Frank Pallone's office and we asked them to help us with South Amboy. And they gave us information on where to get grant money. So there's a disconnect between disabled vets access and our government. We wouldn't have these things if it wasn't for disabled vets, but yet there's no access for disabled vets. I don't get it. There's urban enterprise zones in New Jersey, and there's dispensaries opening up in these urban enterprise zones. These urban enterprise zones give you 3.5% tax. It's a tax break. But if you're in a wheelchair and you can't get into that dispensary in the urban enterprise zone, you can't get the same tax breaks as able-bodied people. And that's ableism. Ableism is just as evil as racism and sexism, and we fight this every day. We need to eradicate ableism. We wouldn't have dispensaries if it wasn't for our disabled vets, but yet those dispensaries opening up all over without wheelchair access. There's a dispensary called Mad Hatter. We are consulting with them and we're fixing any issues they have. Now, the owners of Mad Hatter have a daughter that's in a wheelchair. So they're proactive with this. They're on top of this, like, and they want to donate ramps to other dispensaries, and which we'll get to in a second. We were reached out by Liberty City dispensary reached out to us, and they want us to get help them with their wheelchair access. So we went there. I met with Liberty City, and there's a lot of issues because the town's making them open up in the back. Okay, they have a front door that has access, but the town's making them open up in the back where there is no wheelchair access. So they have to put wheelchair access in. And the timing was such that when I was speaking last month, they were actually considering what to do. So when I went there, we had a great conversation. We talked about things. We talked about things such as talking menus for deaf people. I mean, for talking menus for blind people, Braille menus for blind people. Things sticking out like a counter space or a standpipe is something that a blind person wouldn't want to walk into. And these are things we have to look for. These are things I was ignorant to until people have reached out to me and said, Lefty, remember this, Lefty, remember that. I'm like, I didn't know. I'm just as ignorant as everybody else. And I'm trying to create education for everybody else. And I think that if the CRC mandates, not encourages, but mandates all of these dispensaries to have wheelchair access, you're going to do more than any government entity that has so far in New Jersey. And hopefully you could set a standard for that these governments can get their police stations access, because I can't believe it's a thing that there's police stations without access and post offices. So I think the CRC is in a very good position here to make a progressive change and to do something no other entity is doing and give us, and I don't know if it's compassion or if it's forced compassion, but if you don't have compassion, you need to have it forced on you, because we need to have access. We need access. I went to a few dispensaries. I want to thank Baked by the River for having their dispensary accessible. Liberty City wants to donate ramps to people, so does Baked by the River. And I'll tell you, Cannaboy needs a ramp. We went to Cannaboy in South Orange. They have about a 6-inch step. They need about a 6-inch ramp. They were very open to what we had to say, and they want to help disabled people. The thing is, though, when you put a temporary ramp, a portable ramp there, it's accessible. It's a workaround. But if you guys forced these dispensaries to get these things before they open up, it would be a cement ramp. It would be something permanent where you wouldn't have to ask or ring a bell or knock on a window to come in. That's not accessibility. Accessibility is just hitting a button and walking in. That's what we're looking for. So I want to thank you guys for letting me speak on this. This is a very important issue. It could affect all of us someday. My life was changed in a matter of seconds when I fell at work and I ruined my back. And any one of us can be in a wheelchair at any time. And if you spend a day in a wheelchair, you'll see how bad it is out there. It's ugly. And we're trying to do what we can. On July 10th, we have Cannabis Patient Awareness Day. We're trying to do this all over the country. We're trying to create awareness for patients because they're taking over our day on 710, and we don't want them to take 710 away. 710 should be about patients. You got 420, take 420. 710 should be all about the patients and sick and dying people. That's what we want. And just like I said, we wouldn't have these dispensaries without disabled vets fighting for our rights. So they should be allowed to get into every dispensary in New Jersey. And that's pretty much all I have. I appreciate you. Thank you.
Thank you, Mr. Grimes. Thank you for sharing your thoughts, your recommendations, and your experiences with the commission today. I want to open the floor to any quick questions we have for Mr. Grimes.
I just want to thank Mr. Grimes. Mr. Grimes definitely comes and speaks from the heart. He lets his concerns be known. Definitely gave us a lot to chew on. And I hope you do stay in touch with us. Please, if you can, Mr. Grimes, submit the comments in writing so we can review them on our end and stay in touch with you to see, where we can weigh in and act on some of the things you mentioned. I hope you strongly consider it. So something I'm looking to talk to the team about. But again, thank you. Thank you for sharing and letting us know the concerns of the disabled community. Very important. Very important.
Can I just say that
I think your advocacy is very important. I mean, this is not always on our radar screen, and that's what you do. You keep it on our radar screen. So thank you.
Mr. Grimes, Commissioner Nash, thank you for your comments today. You mentioned these portable ramps, and I wondered, is that a very costly solution in your opinion?
a portable ramp is usually about $100 per foot. Like say Canterbury, they would need a 6-foot ramp. That's going to cost about over $500 for that ramp. But it would be worth it. It would definitely be worth it. It's a fold-up ramp that could be put inside the front door. We've got a lot of businesses. In Bayonne, we got 50 ramps in Bayonne by either just asking them, encouraging, or donating. And it's a very simple solution. It's not the best solution, but it is a solution.
Thank you for that.
Thank you. Any final questions from Mr. Grimes? Seeing no further questions, Mr. Grimes, thank you again for your time and sharing your experiences with us today.
Thank you.
Our next invited speaker is Chris Goldstein. You should be allowed to talk now.
Good afternoon. Thank you so much for taking time to listen to everyone here today. This has been a really insightful afternoon, and the kind of listening session I think that the patient community and the medical marijuana community who've been working on this so long have really looked forward to. So thanks to you all for listening to us today. My name is Chris Goldstein. I'm a longtime advocate here. Ken mentioned being a nurse for 48 years. I'm 48 years old this year, and I've been working on this issue for 25 years. I was there when the original Compassionate Use Act was passed here in New Jersey almost 14 years ago now. Exactly. And the program was always one of the most restrictive and draconian regulated programs in the country. So the New Jersey Cannabis Commission, in being created to accommodate adult use legalization, you've done a pretty remarkable job trying to keep up medical access and shoehorn one of the most restrictive medical programs in the country into what is a pretty open adult use program. So on the whole, in between, 14 years ago and now, there was also the Jake Honing Act, which was sort of an interim fix for what was seen as an interim fix for an expansion of our New Jersey medical marijuana programming. Never really worked out. So I have to start out with your original questions, and I want to address some of those and then get to some of my overall comments. First of all, you asked, can there be more conditions added? Absolutely. I back Ken Wolski wholeheartedly. I used to be on the Coalition for Medical Marijuana New Jersey's board of directors, and Ken and I have spent many hours talking about this, and certainly I agree. There are some states and countries that take the approach of allowing doctors to make the recommendation for cannabis for any condition that they see fit. And that is really how it should be in practice. I will have to point out that the problem here, we've encountered this in some of the talk today. We're in a real catch-22. Doctors are not well educated about cannabis therapy, and they're not well educated about endocannabinoids and the entire system. Yet we are relying on doctors in New Jersey to serve as the access point for patients. Now, that is not traditionally how things were done in medical cannabis programs. In fact, New Jersey was the first state to require doctors to be part of a special registry just to make the medical cannabis registration. So now we sort of broke down the barriers on some of that over the years, but the original program created a stigma that still has to be overcome. My recommendation here is that NJCRC and the commissioners yourselves, you have to be the diplomats here for medical cannabis to the wider mainstream medical community. And we have to have more doctors participating. But we also have to consider this. And there has been talk about the federal Schedule 3. And another interesting side note is that I have a federal pardon from President Biden, and I was invited to the White House in March and again in May. And I've kept up a discussion with the White House and advisors about this whole scheduling thing. It's something I've been involved with at the federal level for almost 20 years as well. Look, Schedule 3 and rescheduling cannabis is an interesting notion, and it is something that keeps physicians from participating in our own state program. We have to recognize that and I've heard this here in the discussion, and thank you for bringing up New Jersey. People talk about it being a pharma state. Well, guess what? There are no whole plants that are available for prescription use in Schedule 2, 3, 4, or 5 at all. And that's why marijuana and cannabis, as it should really be called here in this context today, and should not be scheduled at all. It should be descheduled. So we run into this big conundrum where we have all these bottlenecks with regulations and stigmas. So why are we trying to continue those forward? I would put the premise forward that cannabis is an over-the-counter drug, that basically we allow consumers, adults over 21, to use cannabis however they wish, and they use it over the counter without a doctor's recommendation. And we have had a shrinking medical cannabis program since June of 2022. We are exactly 2 years away from the peak membership in New Jersey's medical cannabis registration of patients. It's gone down from 124,000 to 76,000 today. That's a dramatic decline. And we'll talk about the price and everything in a moment, hopefully. But I do think that we must look beyond the restrictions of the past. There are two things NJCRC could do. We could advocate to get rid of the doctors being the bottleneck, that patients be able to self-register. There is a notion in this because Delaware just passed a bill to allow anyone over age 65 to access medical cannabis dispensaries simply because they're over 65. And we could have a bill coming up for that in New Jersey shortly. But that would allow a certain age group to do that. But I think that all age groups should have that kind of self-registration access. Now, finally, I think NJCRC should strongly consider marijuana with an M is still a Schedule I drug at the state level here in New Jersey. And I do believe that there could be barriers removed if we could deal with scheduling at the state level as well as the federal level. On the point of research, Pennsylvania created 8 research permits with universities and tried to move forward with a research program there. Drexel's and some of the researchers were here today. That never really launched. I have to say that the concept of researching patient outcomes in some realms of healthcare is considered marketing and not really research. I would say that if you want to do an effective research program, it has to bridge the gap of what the federal government can't do, which is somehow get some research on the plant itself. As far as patients themselves, there has been a notion that there needs to be more advisors and patients. Absolutely. This is a medical cannabis program that migrated from the New Jersey Department of Health. You at the CRC need to create a health framework for this program. That must include a board of patient advisors, scientific advisors, and medical advisors in order to make sure that this program proceeds forward, because I think it should. The same operators who are dominating the medical cannabis businesses here in New Jersey operate in Pennsylvania, and they charge half as much for products in the state next door. There are 450,000 patients in Pennsylvania who go to about 180 dispensaries served by 32 grow operations. Quite frankly, the states have very similar regulations, and there are some big questions as to why they have so many more registered patients. But I've also heard lobbyists from those companies say that they're willing to give up on the medical program as soon as adult use gets legalized there. So I have to put forward this premise as well. And this is a duty of the NJCRC, I believe. It's your job to make sure that we have fair players in this market. Patients are doing their best. People are willing to register. But if they're not offered fair pricing and options to have true medical access, I think that we'll see a decline in patients continue. And part of it is because the industry has given up on the program, not because the CRC or patients have given up on it, but because when I look at menus, in New Jersey, there's only 14 selections of flower. In Pennsylvania, there's 150, and the prices are much lower. So thank you for hearing me out on all this. Thank you for hearing all of us today. And I do welcome any of your questions, but thank you again for making sure that there's an open line of communication here, because I do think that you have a responsibility, maybe as the CRC, that the Department of Health took on naturally, that the CRC has to take forward thoughtfully. So thank you.
Thank you very much, Mr. Goldstein, for taking the time to share your thoughts and your recommendations with us. Any questions from the board for Mr. Goldstein?
One brief question, Madam Chair.
Commissioner Barker.
Same question, Mr. Goldstein, and thank you again for your leadership and advocacy, not only here in New Jersey, but especially in New Jersey, but across the country. Just want to pose the same question to you. New Jersey's position as a pharma capital, the clinical registrant component of the program here in the cannabis program here in New Jersey, soon to come. What does equitable research and development, what does equitable and inclusive and safe clinical registrant program look like to you?
That is a great question, because New Jersey, as you say, is this pharma capital, and cannabis doesn't fit into the pharma model. That's why you have such a challenge in creating a better place for public health with a robust medical cannabis program. This really is important to solve. We shouldn't give up on solving this problem. We should not let this program and see the patients diminish off to zero. This is an important part of the fabric of public health. At the very beginning of the meeting, Chairwoman Waynu mentioned Juneteenth and Pride and the history in the community here. We have to recognize that there is a medicinal use of cannabis that is part of culture. And now it's part of American culture. It's part of New Jersey culture, quite frankly. That there are many more people out there in our society every day utilizing medical cannabis on the daily basis here without interacting with us at all. The medical cannabis program is a sort of exercise in trust between the state and the community. And so what does equitable research look like? I agree with Leo that it has to look like research that is actually in the community. I don't agree with some of the scientists who want to monitor medical cannabis patients with a prescription drug monitoring program. I think that's the opposite of the approach. How are you going to get people to register if they think that they're just going to be guinea pigs for the state? That's already what happened with this program, and we should avoid that. I also think, Commissioner Del Sincoso, you mentioned HIPAA compliance, and there was some mention of that. One of the real problems with dispensaries, and not just in New Jersey, this is national, is that there is not much privacy for patients once they join. Think about how much data and information you're giving a medical cannabis dispensary and the business behind it. You're telling them your medical conditions and how much cannabis you're using, when, how much you're spending on it. That data should be private. It shouldn't be traded, which sometimes it is. So when we talk about HIPAA compliance, for me as a consumer and patient advocate in this space for 20 years, I would love to see the kind of privacy protection that we enjoy every day in mainstream healthcare come into medical cannabis. When we talk about the insurance bills and things like that, I've worked with Senator Singleton on those bills. I believe in one day having state insurance cover medical cannabis. But again, this is where we have to think outside the box. It will be a long way down the road, no matter how much progress we're making federally right now with the White House and the scheduling review. It will still be a long way down the road. And in between, NJCRC and the state of New Jersey has a responsibility to our residents right now for these programs to work, because they can. Back to the center of equity that you asked. How do we center equity on research? We've talked about the equity that is in the businesses, but how do we get equity back to the people? I think that it really comes back to, having people participate in the program and trust the program, trust the laboratory results, and trust that they won't be treated like guinea pigs.
Thank you very much for that, Mr. Goldstein.
Thank you.
You mentioned
Yes,
over
Vice
the
Chair
counter.
Delgado.
You mentioned over the counter. Can you expand on that a little bit? Are you saying have it available over the counter in a pharmacy?
Yeah. Okay, so essentially in Delaware, Governor Carney last week signed a bill that was passed by the legislature to allow anyone over the age of 65 to access a medical cannabis dispensary without a doctor's recommendation or anything other than a state ID that says they're over 65. They're not the only state to do this. That essentially gives seniors over-the-counter access to medical cannabis. And that is a great thing in so many ways, right? Other than the fact that when they get to the dispensary, they get scared away by the prices because it's like the most expensive weed they've ever seen in their life. And that's where we have to get into fair pricing. New Jersey's prices, again, as I'm pointing out, are double what they are in Pennsylvania. and more expensive than they are in Delaware, and in some cases more than New York City. That's a problem, okay? And that's a problem for access. We were told, you were told, I was there, I was at the meetings. They made promises to y'all like 2-3 years ago, hours of promises. They testified about patient access plans. And their main theme was that prices would go down and they would get more affordable. I look at the menus every 2 weeks. I do the price studies. The medical and adult use menus are of equal price. They're charging 10 years ago when we first opened dispensaries, it was $60 an eighth. The Star Ledger published articles from the CEOs saying, oh, we'll get more grows open, more competition, prices will go down. Never happened. Now they're selling $60 an eighth marijuana. If we want insurance access in New Jersey, and I've talked with Senator Singleton about this, built into that insurance bill is price transparency. Because if consumers and patients aren't getting a fair deal, taxpayers won't get a fair deal from these companies either. And that does come down to your responsibility. Like, how does NJCRC negotiate those prices? Like, this is a conundrum that we're in with other realms of healthcare. But because there's no federal regulations for this, you have the responsibility to be the price negotiators, to be the ones to get the prices down for consumers and patients. And when these same companies are charging double in New Jersey and charging more in New Jersey than any other dispensary they have in the country, and when they're operating in 12 to 17 states, that really says something. Then, I mean, what do? You're going to have to be the diplomats that the state needs here to stand in here. And that's tough. But again, you're teaching the lessons that the federal government needs to learn real fast. So the examples that you're setting right now of getting fair prices, of negotiating with this industry, this is something that carries forward at a national level pretty quickly. This is a pharma state. So we've negotiated with pharma companies to get better prices on pharma drugs. This is now your realm to get better prices in this realm of care.
Yeah, the only thing I'm thinking about here, Chris, is that like over-the-counter drugs are not, you don't get insurance on over-the-counter drug, right? Like if I go.
That's not true. Acetaminophen is, I mean, again, you can
Like if
cover
I go get
over-the-counter drugs
Xanax,
with
I can't, my insurance company won't pay for my Xanax, right?
But again, your insurance company, what we would have in New Jersey is a specific insurance program that goes through Family Gold and those programs to pay for it. So while Xanax may be cut out of your specific healthcare plan, we would make available healthcare plans, especially for, and this is for people who can't afford these prices. So again, without home cultivation, without price controls, we've got an out of control price model that is not affordable, and we can't even pay for it with state resources. So that's
that would be in the sausage making of the legislation, right?
However, again, it might be in the sausage making of the legislation, but my appeal to you is that what you can do is say, Commissioner Delgado, you can look at the menus of these companies in Pennsylvania. You can yourself see that they're charging double in New Jersey.
No, I know.
So, on a level, there has to be a more transparent to the public approach to these companies on pricing, just like politicians do with the big pharma companies that are based here anyway. Look, if they can negotiate the price of Xanax down, you've got to be able to negotiate the price of a gram of weed down for a medical patient, okay? And when it's double, I have to say, the same lessons, I mean, the President of the United States, President Biden, and members of Congress are talking about corporate greed, price gouging, and how that affects working class people every day. And, that's their role in that realm of pharmacare. Your role is medical cannabis care. So you're stuck between these companies and the public. So it's your job to negotiate the better prices.
All right. With that, any last questions for Mr. Goldstein? All right. Thank you again, Mr. Goldstein, for sharing your thoughts and answering our questions.
I appreciate your time. Thank you all so much.
Thank you very much.
And last but certainly not least, Dr. Hugh Blumfeld of Doctors for Drug Policy Reform, formerly DFCR. You should be allowed to talk now.
Hi, everybody. Can you hear me? Hello?
Hear you.
You can hear me? Okay, great.
Yes.
Thanks. Hi, thank you for inviting us to speak. I am a member of the Doctors for Drug Policy Reform. I just want to mention, I'm not speaking officially for them or representing them. I'm just a member, and they asked me to speak because of my experience with medical cannabis over the years. So just introduce myself. I'm a family physician, and I teach family medicine in Hartford, Connecticut since 2010. I have a full scope practice. I do children and adults. I do obstetrics. I do hospice. Take care of adolescents, and I have a psych clinic as well. And it's in the middle of Hartford, which is not that different in some ways from Newark, where my mom grew up. I wanted to start with a little story, though. Before I became a doctor, my sister-in-law had been diagnosed with MS for a long time, multiple sclerosis. And she told me on the side when I started considering going back into medicine that she wanted to make sure that I learned about medical marijuana because she said that without cannabis, she would certainly have committed suicide. That she had neurologists, many neurologists over the years. Nobody could really manage her pain, her symptoms, until she was able to get medical cannabis. And she wanted to make sure that, when I became a physician, that I would learn about it, which I tried to do. So what I wanted to address for you today is just talk about how we've been doing medical cannabis in Connecticut, talk a little bit about the qualifying medical conditions, and also a little bit about how we've managed healthcare access, healthcare provider access to make sure that more are on board. There's a lot that we don't know about cannabis, how it works. We do know that there are receptors for cannabinoids throughout the brain and the central nervous system, but also throughout the immune system in the body. And so that it makes sense that it modulates the conduction and perception of pain signals, as well as modulating inflammation in the bodies. We know that THC and CBD are two of the most well-known of the cannabinoids, but then there's also a number of dozens of terpenes, which are smaller chemicals that give marijuana its flavor and taste and scent, and have therapeutic qualities themselves, which again, there's a lot to be learned about the way cannabis works, but we know that it has over a 4,000-year history of use medicinally. We know that the AMA had it on their pharmacopoeia before it was made illegal back in the 30s, and protested against it being taken out of their pharmacopoeia. And another thing is that in a lot of conditions, we lack really good alternatives to manage symptoms like the ones that we're trying to treat. And some of those medications that we do use have their own dangers. There's opioids, there's Tylenol, which has many overdoses of Tylenol a year. That's why they don't package it with opioids anymore. NSAIDs cause thousands of complications that end up in the hospitals that I take care of. We have benzodiazepines like Xanax and Valium. Somebody mentioned their Xanax prescription, but these are highly habit forming, very difficult to get patients off of once they've been on them. Ambien as well. And that's not to mention things that we've tried to make illegal, but we're not successful, like alcohol and cigarettes, which people have pretty free, adults have free access to, that are much more dangerous than cannabis. So from a physician point of view, I've been very interested in the medicinal possibilities of cannabis, but also really interested in harm reduction, because the fact of the matter is that working in Hartford, a lot of my patients have access to or already use cannabis. And so there are advantages to having medical marijuana system, medical cannabis system. So in Connecticut, we have actually 40 conditions that are listed for adults, and 11 conditions that are qualifying conditions for children, people under 18. And when I think about the difference between New Jersey's list of 17 conditions and Connecticut's list of 40, it makes me wonder about the usefulness of trying to find every single condition that there might be evidence for cannabis being effective. So I really wanted to break it down into just a few basic categories that I think all these conditions fall under. One of them is chronic or recurrent pain syndromes. Another is neurological disorders. Another one is psychiatric conditions, including substance abuse and PTSD, and in New Jersey, I think you've included anxiety. There's chronic inflammatory or immunological conditions. A lot of them are autoimmune, or some are infectious. These things include things like MS, but also HIV. And then there's congenital or acquired conditions affecting the musculoskeletal system, a number of those. And then finally, there's some terminal illnesses. And I think, I'm not sure how much sense it makes to, try to, there's thousands of conditions that fall into any one of these categories. And if you look at the differences again between our list and your list, it's just a matter of adding some specific conditions within those major categories. The way that we work it in Connecticut is that this physician is supposed to have a pre-existing relationship with the patient, a therapeutic relationship with the patient. We're trying to avoid situations where people just set up shop as marijuana doctors. But it does mean that more doctors have to get on board with understanding how and when cannabis can be used by their patients. But if you have a bona fide therapeutic relationship with a patient, you can certify them for these medical conditions. And the nice thing about the Connecticut system is you don't actually prescribe the cannabis. Basically, once you've certified the patient through the Department of Consumer Protection, they have a website. Patients are then able to go to the pharmacy at the dispensary and have a 40 to 60-minute appointment with a pharmacist. And the pharmacists who work at our dispensaries, our medical dispensaries, are highly knowledgeable in cannabis and the various kinds of cannabis that are available to patients. Not only the different blends, which are therapeutic for various conditions, but different modes of routes of administration. Typically, people using adult use marijuana will smoke or vape it, but there's not only ingestible cannabis products that you can eat, and then they go through the GI system. They take about 45 minutes to an hour to start working, but they last longer. And then there's even sublingual products, which get into the bloodstream much faster, more on the order of smoked or vaped products. So, and these things are safer than smoking or vaping. The other thing about the dispensary system, and this is to address, I think Mr. Delgado had questions about, the illegal markets. The kinds of cannabis that are available at the dispensary really can be blended to address medical symptoms. Most of the cannabis that's available either illegally or for adult, what they call recreational use, the idea is to, get euphoria, to get high. But when you're talking about therapeutics that can calm PTSD, which is not necessarily an anxiety syndrome anymore, but more thought of as a disorder of the sympathetic nervous system, that fight or flight system, you can get products that really address pain, especially neuropathic pain, or address inflammation. Most of the people I have that are trying to use cannabis medicinally, they want to stay functional. They don't really want to be high. And therapeutic blends really address that need for patients to be able to ameliorate their symptoms without getting that euphoria that can make them unable to function. And I think, and because we have these dispensary pharmacists to have these one-on-one conversations with patients, physicians don't have to be as knowledgeable about cannabis. They simply need to know if their patients have a condition that would benefit from it. And then it's like a specialist referral. So I think I probably used your 3 minutes, and I think I'll stop there and see if there's any questions or things that I could address more fully for you.
Thank you so much, Dr. Blumenfeld. Really appreciate the time. Commissioner Nash, do you have a question for
Yes,
Dr.
hi,
Blumenfeld?
Dr. Blumenfeld. Thank you for your time today and your comments. Really appreciate it. So I just want to understand, are there pharmacists in every dispensary?
Yes.
Okay. And are they there daily? I mean, in general, I'm just trying to understand.
No, there's in Connecticut's dispensary, my understanding is that there's a full-time pharmacist in each one. And I have visited the one in Hartford. It's quite amazing to go back and look at it. It looks like the pharmacy in Walmart. It literally has, the same shelves with the same kind of, packaging and bottles with, everything's very formal. In terms of, one of the advantages is of medicinal cannabis is you really can break out the percentages of THC, the percentage of CBD, the percentage of specific therapeutic terpenes that are in any given blend, and the exact number of milligrams that a patient will be consuming.
Well, thank you for that answer.
Thank you. Any further questions? Dr. Blumenfeld?
One just quick clarifying question. You mentioned that and I could have confused you with another speaker, but did you say that you had some experience working in long-term care facilities?
Not in facilities, but I'm a medical director in a hospice program.
In a
So
hospice,
the
okay.
nurses and social workers that I supervise, they go into a lot of facilities, including inpatient units, to take care of patients there. But a large number of those patients are at home.
Got it. Yeah.
And yeah, and the long-term care facilities don't allow us to give patients medical marijuana there.
Okay, I was just going to ask that question because I'm thinking about institutional caregivers here in New Jersey, and how, I wanted to ask if you had some wisdom to share with us in terms of how hospice cares are addressing that issue. But thank you for your short and quick answer.
Welcome.
All right. Great. Well, thank you so much, Dr. Blumenfeld. Really appreciate you taking the time to share your experiences and insights, especially on what's happening in our regional neighbor up in Connecticut.
Yeah, thanks for having me again.
Mhm. I believe that is it for our invited guests. I want to thank everyone again for sharing their thoughts and their expertise with us. And so now we will turn over to the members of the public who have signed up to speak. We will have, I believe, Mr. Saeed or Director McWhite call out our registered speakers. Members of the public who are registered to speak, you will be limited to 3 minutes. When it is your turn when you hear your name called, please use the raise your hand feature in the Zoom platform so that our staff can identify you and unmute you.
Madam Chairwoman, before the speakers start, if I could just correct the record real quick. When we were talking, when Chris and I were talking about over the counter earlier, I said Xanax. That is a prescription. I meant Zantac. In my Bronx accent, I said Xanax by mistake. So I want to correct the record. Thank you very much.
Thank you. No problems, Vice Chair Delgado. And trust, there will be no judgment from us whether you have for either medication.
Well, there better not be.
All right, we'll turn it over to Mr. Saeed to call out our registered speakers.
Thank you, Chairwoman. As a reminder, public speakers during this afternoon's public comment period will be limited to 3 minutes. Please be respectful and concise during your comments. I'm going to call out 3 at a time. Velvet Howell, James from STEMS Inc., and Ronald Sykes. If you're in the Zoom meeting, please raise your hand. The next 3 I'm going to call are Deanna Robinson, David Fetter, and Margarita Tsalyuk. As a reminder, please raise your hand so that I can allow you access to speak. The next 3 are Haider Rizvi, Samuel Reichbart, and R.H. Robinson. Okay, I see Samuel Reichbart. Just give me 1 second. Samuel, you have the floor.
Okay, give me 1 second. All right. I just wanted to say, first off, thank you guys for implementing virtual testimony for future meetings. This is a great step towards patient accessibility, along with steps towards fixing in-person accessibility issues at newly opened dispensaries. Seeing patients pushed to the side at places they're supposed to be able to access relieving therapies is quite disappointing. I'm glad to hear that the commission will be taking steps to right some of these wrongs. I also very much appreciate that you guys asked an educated group of doctors and professionals to come and give testimony on some issues that the commission and the program have been experiencing. It does not go over mine or anyone else's heads, though, that you guys still refuse to speak to the patients directly affected by these issues. We have valuable voices and suggestions that could help to ease some of the tension and to help this program to continue to grow into what it's supposed to be, as well as foster trust between the public and foster growth in this industry. I would also like to parrot a couple of points. Ken Wolski was absolutely correct in his recommendation that any doctor with prescriptive power should be able to recommend or authorize cannabis for any patient or condition that they deem it will be therapeutic for. You guys are not exactly doctors. And I don't know why you guys would task yourselves with coming up with this list of conditions, not being doctors. It's too complicated and there's too many things to potentially think about that you need to involve doctors in that decision-making process. I think that would be made a lot easier if you were to hire them internally as a scientific or medical advisory board. Patients have been waiting for this step to be taken as well, because many of the decisions that you guys are tasked with making are scientific and medical decisions. They need to be weighed in on by people that truly understand the things that you guys are making the decisions on in order to, make sure that patients have the best outcomes possible. Additionally, the group of doctors that spoke first had an excellent point in that clinical education is going to be utmost important over the next few years. We have gone for too long with doctors that are unable to help and answer our questions. Patients seek out real science-backed information from from very genuine resources, and we currently struggle with that, and so do the doctors that we would get that advice from. Someone mentioned it earlier, but the best place to get that information is currently inside of the dispensaries. But inside dispensaries, we have our hands tied. I work in a dispensary. I'm not able to give medical recommendations, even though I have a deeper understanding than probably most of these people's doctors. I'm not allowed to. I have to be very careful about the words I use and what I say. And that doesn't really help anyone, because they're coming to me because they've been told that I'm the person that can give them advice. They know that their doctor doesn't have the information that they need. And it just doesn't really help anybody for us to not have this knowledge and not have any professional to go to in order to ask these questions. Additionally, while it's great to hear from these professionals,
5 seconds, Sam.
there are still quite a few things we are waiting for. We're still waiting for testing batch size, hospital access, requiring COAs to be posted online by producers. All of these changes would help to foster accessibility and trust for the program, producers, and the commission. And finally, patients are still waiting for solvent transparency on packaging. Patients are at risk because of your woeful lack of knowledge and failure to properly define and regulate RSO, which is a highly unique product. My efforts to solve this issue have been going on for over 6 months.
Sam,
you guys need to take steps to work on this issue. This affects sick people. You
Sam,
regulate
thank you so
our
much.
medicine.
Thank you so much,
Because of
Sam,
your
for
lack
your
of
time.
understanding.
Next up on the list is Deanna Robinson. Deanna, please speak.
Can you see me now?
Yes, we can hear you, Deanna.
Oh, listen, first of all, I want to thank you so much for the special guests that you had, and also for extending
Very rude of you guys to cut me off instead of letting me finish. I had literally 30 seconds. You can't take the time to listen to patients, and it's disappointing. This
Mr.
commission
Reichbart?
needs
Mr.
to
Reichbart?
step up and do.
Mr. Reichbart, I want to interject here for a second. Apologies, Mr. Reichbart, for the technical cutting off. You are out of time, and we will make sure that we highlight for folks. Unfortunately, our counter, our clock timer is not working with us right now. We've had some technical difficulties for this, but I want to thank you, Mr. Reichbart, for sharing your thoughts, and encourage you to, I want to invite you to submit written comments for anything that you weren't able to get to. I know we do have
You regulate our
lot
medicine.
of,
You need to
excuse me,
act like it. Your lack of
Reichbart,
understanding.
Mr. Reichbart, I'm sorry. We're gonna have to ask you to submit your comments, the remainder of your comments in writing, so that we can get to the rest of our registered speakers. And I want to take this time to apologize to Ms. Robinson, and also remind all of our registered speakers that you are limited to 3 minutes. We do have several folks who have signed up to register. I'm sorry, who have signed up to speak, and we want to be able to give all of those individuals an opportunity to share their thoughts. So I ask that everybody remain cognizant of the time limit. Please feel free to provide any additional comments in writing to us, and those comments are shared with commissioners, and they are posted online, so that your comments will be publicly noted. With that, I want to turn back to Ms. Robinson, and your 3 minutes starts now. Apologies, Mrs. Robinson, to you.
Oh, that's okay. I understand. He's very passionate, but I am very passionate about thanking you and thanking Mr. Glenn Walker for being a great coordinator. And you guys are wonderful. I enjoyed my ride down to Atlantic City listening to all your guest speakers. Now, there are a couple of comments I'd like to make. Number one is, if the schedule changes from 1 to 3, how does that affect dispensaries? And will pharmacies like CVS and everything else figure that they can make more money, giving out medical cannabis? That's one thought, okay? And I know that's way down the line, but it is a thought, because a lot of dispensaries are going to expend a great deal of money and possibly lose money. Number two is that I'm having a very hard time finding a location. That's why I asked for an extension. It's really tough out there. And I was wondering if some of the people that are out there, such as myself, can volunteer and help you guys talk to other townships to maybe get more people to opt in, because I've been out here for a minute, and I have 2 realtors that are trying, but every time I get there, either the licenses have been taken or the townships don't want it. Okay. So then the third thing too is because the gangs have been running the streets for so long, are you setting up a round table to discuss their territories that are going to be invaded by legal dispensaries? You realize that before the dispensaries or the retail stores that are opening, that the gangs were selling the drugs. So, I'm wondering about some of the backlash from that, like in Camden, Newark, and other areas like that. Are there roundtables that are being set up to discuss this with the leaders? Just questions. All right. So could you take that into advisement or get back? Mostly the list of the locations I really need to know what new townships are opting in. All right. Can you guys hear me?
Yes. Thank you very much, Ms. Robinson, for
I was short, right? Was that 3 minutes?
You were short. I thank you. I appreciate the conciseness.
All right. So listen, have a great weekend. And hopefully if I'm here still tomorrow, if I don't go busted, I'll come and visit your place in Atlantic City. All right. Bye-bye, guys.
Thank you.
Bye.
The next three speakers on the list are John de los Santos, Carlos Almanzar, and Anthony Campbell Jr. All right, I see Anthony Campbell. Anthony, you have the floor.
Hi, can you hear me?
Yes.
Hi. Hi, Commission, and thank you for your time. My name is Anthony Campbell. I am the founder and CEO of Culture Craft Cannabis Collective. We started this journey years ago, and we are happy to have finally completed our initial investigation phase with the CRC. So thank you again for your comments earlier about the 4 weeks for review before being on an agenda. That is very helpful. And we've submitted our follow-up documents in time to meet the July meeting. We know that you guys been working extra hard to push applicants through. So just want to thank you for all that you do and hope that, before you guys go on break in July, as many of us who've been waiting can hopefully get on that list. Because as you know, every month can come with its new set of challenges and every month counts. A little bit about myself. I'm a Jersey boy, went to Bergen Academies for Science and Technology in Hackensack before going to Michigan for chemical engineering. Then I went to work in industry for L'Oreal, Johnson & Johnson, and the pharma capital in New Jersey, as we talked about earlier, for over a decade before I went to study health sector management at Duke. So today's conversation I found extremely interesting. And beautiful. My team and I cannot wait to bring our decades of formulation and product development experience to the market. We truly are homegrown, 100% local, and our goal is to simply have the chance to build a quality cannabis brand and help supply ourselves and other micro cultivators with quality genetics. And I'm a science guy through and through, so I'm curious to see the role that we could potentially play in the future. As collectively we unlock all the benefits of the cannabis plant. We're unlocking new uses every day. I've been researching this in the endocannabinoid system. In fact, just from my experience in industry, I've had a thing to research cannabinoids in personal care products and topicals. So I'm excited to see where the industry takes us and how we could all play a part in an equitable manner. But just wanted to introduce myself, our company, Culture Craft Cannabis Collective, and say thank you. We are 100% minority-owned Class 1, Class 2 micro business, and we are excited to see where the industry goes and to play a part. So once again, thank you for your support, your time, and consideration now and in the future. Thank you.
The next three on the list are Andrea Rabel, Jessie Marie Villers, and Daniel Vargas. If you're in the room, please raise your hand so I can allow you to speak. I don't see those names. I'm just going to go over the names one more time just to give everyone an opportunity. Velvet Howell, James from Stems, Inc., Ronald Sykes, David Fetter, Margarita Tsalyuk, Haider Rizvi, R.H. Robinson III, John de los Santos, Carlos Almanzar, Thomas Norcia. Okay, I see you, Thomas. Okay, Thomas, you have the floor.
Hello?
Yes, we can hear
Can
you,
you hear me?
Thomas.
Yes. I'm Thomas Norcia. I'm the owner and operator of GrowWorks. I'm a small cannabis business in Sussex County. I'm licensed through the New Jersey Department of Agriculture. I've been growing and
Thomas,
yes.
go ahead. You were muted for a second, but go ahead.
Sorry.
Thomas, you're muted again.
I have products in the dispensary in North Jersey. Recently, an inspector came in and told them that they were no longer to sell the products until they were put into metric. So today, my one thing is just seeing if we could start the conversation on how we could create a gateway to allow cannabis businesses that are licensed through the Department of Agriculture to have access to Metric. So that's really it for today. Just want to see if we could get that a topic on how I could get products into dispensaries.
Thank you so much, Thomas.
If there's any questions, anyone wants to ask questions, I'm still here.
I don't think we're gonna ask questions
Okay.
of the public, but thank you so
Okay.
much.
All right, thank you.
Next is Andrea Rabel, Jessie Marie Villers, and Daniel Vargas. Okay, I don't see any of those names. Chairwoman Wainu, this will conclude the registered speakers we have for today's public meeting.
Thank you, Mr. Saeed, and thank you to everyone who shared their thoughts, recommendations, and their experiences with us. Again, anyone who was not able to finish their thoughts can submit their comments in writing to the CRC via our website, nj.gov/cannabis/meetings. And the deadline for submitting comments for today's board meeting is 5 o'clock tomorrow, Tuesday, June 18th. So this concludes the business that we have before us today. And with that, I move that we adjourn.
Madam Chairwoman, I move that we adjourn.
I second.
All right. So we'll say that Vice Chair Delgado has moved to adjourn and Commissioner Nash has seconded. Any discussion on this motion to adjourn? Hearing none. All those in favor of adjourning say aye.
Aye.
Aye. All those opposed say nay. Any abstentions? Motion passes. The time is 3:29 and we are adjourned. Thank you, everyone, and have a great rest of your day.
Thank you.